All right, good evening, everyone. Welcome to today's CME. I'm Cornelius Sendagire, and together with Dr. Rasmus, I'll be moderating this session. So just to make a few remarks regarding this CME, we shall have 4 presenters, as you're all aware, from the allow me to move the slides. We're going to have 4 presenters, each of whom will be discussing a particular aspect on cardiovascular medicine in the ICU. And following that, we shall have, in between them, we shall have quizzes just to test our knowledge in physiology, and as well as have those quizzes be part of the discussion at the end of each of the presentations. And after that, we shall have a wrap-up of the session with a summary of the learning points from today. And this is a build-up to more CMEs in cardiovascular medicine, especially with clinical pathology that we shall be seeing in the ICU relating to the cardiovascular system. So allow me therefore to now commence the Aau-Icsu Critical Care Seminar, and also remind you that we shall be having the AAU conference this month at the end of the month, between the 26th and 28th of October, and it will be in Ginger. And I hope that we shall see you there. So to begin us off regarding the CV physiology, we are going to mostly look at why this is important, and we are going to try to understand, just a second, going to slideshow, and we're going to try to understand the central nature of cardiovascular physiology and function, both in health and in disease, and then look at a broad array of mechanisms of disease leading to circulatory failure, and then a broad array of interventions available for specific diseases. And all this leads into personalized medicine for the patient at the bedside. So the objectives of this session are going to be to appreciate the basic and in-depth concepts of cardiovascular physiology, and then understand the concept of perfusion and shock, as well as understand the implications of cardiovascular dysfunction in critical illness. So we shall be going to our first presentation, which will be on volume and its relationship to the cardiac output. That is going to be presented by Dr. Esther Nduwati, who is a third-year resident in emergency medicine in Makerere University. So Esther, I will invite you to present your slides. I will stop my share here, but perhaps as you prepare to present your slides, I'm going to launch the first poll related to the talk that you're going to give as you launch your slides. So I will invite everyone to respond to this poll. And this poll is specifically about cardiac output and venous return. So please feel free to start responding to each of the questions. We have about 6 questions, and in those 6 questions, there are true and false answers that are easy to respond to. So the first one, we are going to take about maybe 5 minutes. So at 17:10, we shall close the poll, and then we shall go into the talk by Dr. Esther to talk about cardiac output and venous return. So the first question of the poll, I hope if you can't see the poll and you're using your phone, you can tap the 3 buttons on your left lower corner that has more, and then tap polls and quizzes, and that should bring up the poll so that you're able to respond. And we shall take about 5 minutes. So 5 minutes has passed, and there's only there are very few people that are responding. If anyone else who can't hear me, I've just received a message that I cannot be heard. Esther, are you there? Can you hear me?
Yes, Dr. Cornelius, I can hear you.
All right. Okay. So I think just please try to respond to the polls so that we can get moving as soon as possible. And the polls are really there. Don't worry about being wrong. We are all here to learn, so feel free to click the answer you feel is most correct. All right, so far 2 minutes have passed. The first question in the poll is about the heart. The heart cannot pump out more than it receives. Is that true or false? Which of the following? The second question is regards to the cardiac output. Which organ receives the highest cardiac output? And there are 4 organs there: brain, heart, liver, and kidneys. Just tap whatever organ you think has the cardiac output. And then the second question relates to determinants of cardiac output. Which of them is true between stroke volume? Which of them is false because you're asking for except. So which of them is actually not true? So stroke volume, heart rate, arterial blood pressure, afterload. Which of those is actually false? And then fourth question relates to circulatory system and volume. Again, looking for the false answer. Is it systemic? Is the systemic circulation they have less compliance than the pulmonary circulation? That the systemic veins hold more than 70% of the intravascular volume. Intravascular volume has both stress and unstressed compartments. And then I'm here to learn is an acceptable answer. Fifth question relates to the circulatory system. Which of the following is true? Whether stressed or unstressed volume is a myth. And then at rest, do we have more than 30% of unstressed volume? Or is it more, or is it less? And then increased vascular capacitance reduces stressed volume. Is that true or false? And then mean systemic filling pressure is the same as the mean circulatory filling pressure. Is that true or is it false? And then if we are here to learn, just tap I'm here to learn, and that's all good. The final question relates to increase in venous return, and all those factors, any of them, do they increase venous return? Which one doesn't? Select the one that doesn't. And if you don't know, please feel free to say I'm here to learn. That is also acceptable. So we have about 30 seconds to close the poll, and then I hand over to Dr. Esther Nduati to take us through this discussion. And then hopefully while she discusses this, she'll be able to give us the answers. And in case she doesn't, we shall leave these answers for discussion at the end. So allow me to close the poll now, since we've run out of time, and then hand over to Dr. Esther. Dr. Esther, over to you.
Thank you, Dr. Cornell. Am I audible, and is my screen
Yes.
visible?
Yes,
okay.
We can see both and we can hear you.
Okay. Good evening, everyone. Thank you for logging in and joining this discussion today. My name is Esther Nduati. I am an emergency medicine resident here at Makerere, and I'll be taking you through volume and its relationship to cardiac output and venous return. So to begin with, I wanted to remind us a few basic principles about the cardiovascular system. And one of the basics that we have to have in mind is blood flows from a higher to a low pressure gradient point, and then contractions Contraction will always increase the pressure in a chamber. In this particular case, you're talking about the heart and the vessels or the vasculature. And then when valves open, valves will open and close according to the pressure gradient between different compartments of the cardiovascular system. Just as a reminder of the cardiac cycle, ideally, when you have your sinus node that will cause an impasse, that impasse will definitely then cause, let me look for my cursor, I'm sorry. Okay, so here you have your sinoatrial node that will generate an impasse. The impasse will then be transmitted to initiate the cardiac cycle. So beginning with an atrial contraction, on this particular slide, you can see a number of waves or graphs that represent different things. So when you're having your atrial contraction, that represents your P wave on your ECG, machine. And what happens during the atrial contraction is that you have definitely your atrial volume pressures going high. You will also have your mitral valves just a bit need to open up, and then at that particular point, the volumes in the ventricles are not so raised, as you can see from the wave on the pink wave in that particular phase. So ideally, when the atria contracts, the ventricle has been receiving blood passively. So the atrial kick or the atrial contraction will just act to sort of pump up the remainder of the percentage of the volume that was required to be able to reach the preload, so that to facilitate ventricular contraction. So in that case, you have that isovolumetric contraction period where there is ventricular contraction, but there's that isovolumetric period where there is contraction, but the pressures are not very high for the valves, for the atrioventricular valves to actually open. So they're actually just raising the pressure in the ventricle so that then it can facilitate the opening of the atrioventricular valves, so that now you have blood flowing to the ventricle. Once that happens, so the opening of the atrioventricular valves will give you your first heart sound in that case. Once that happens and you have once that happens, then the remainder of the injection of the, sorry, I was talking about the ventricles. The remaining of the contraction of the ventricle will then then cause the blood to flow out of the ventricles into your aorta, and that will constitute your systolic or your contractive phase. So you have your atrium that will contract, and then once your atrium has contracted, the pressures in the atria will go high, and that will be represented by your P wave. And then you have your ventricular contraction that will represent the injection phase. And during that injection phase, then you have your body, the pressures in the ventricles will go high, and that will be represented by the ventricular pressure that is shown in blue. At that particular time, you're also having your ventricular volume reducing in this case, and that will represent your QRS complex in that case. So your second heart sound will come in when you have your atrial, your mitral valve and your aortic valve closing, in preparation for the relaxation period, where the ventricles will now go into an isovolumetric relaxation period, so that it can now start receiving the blood passively from the ventricles, from the atrium, and then once that happens again, then the cycle goes on, and then we go back to the P waves. So the P wave represents your atrial contraction, your QRS will represent your ventricular contraction, and during all these times, we have differences in pressures and differences in the ventricles that are taking part in every cycle of the heart. So once you get to the P wave again, the cycle goes back to normal, and we start again another cycle like that. So another thing you have to have in mind before we start this discussion is the relationship that has been discussed about the cardiac muscles by the Sterling law, that explains that the muscle can contract up to can expand up to a particular point, where if that critical point, the expansion that comes about because of the volume that is being increased in the ventricle will help in the recoil force to help in the contractility. But if you exceed that critical point and you expand more than that, then the muscle will not be able to contract as much or as well as it could have contracted. To try and explain this, if you try and form a wrist with your hand, when with your relaxed hand, you try and form a fist without flexing your wrist, then it's easier to actually form the fist when you haven't flexed your wrist. But the minute you flex your wrist and then you try to form a fist, then you feel it's harder for you to form the fist with a flexed hand. So it's the same thing. So there is that initial expansion that will account for the elasticity and the recoil force that will be needed to actually help with the contraction of the heart. But if there is more expansion beyond that critical point, then the muscle will not be able to contract as much. So that's why we are seeing there's, of course, that linear increase. When the preload is increasing, cardiac output increases until it gets to a point where the graph doesn't increase anymore and starts sort of flattening out. That is what that particular graph explains. However, in the effects of increased inotropic effect or increased or reduced afterload, then this graph will shift to your left because the inotropic effect will help with the contractility of the heart, and the reduced afterload will reduce the resistance or the force that the heart needs to pump against. Vice versa, if you have a reduced inotropic effect, then the contractility of the heart is reduced, and if you have an increased afterload, then there is the pressure that the heart needs to pump against is increased, so it's also going to affect the contractility of the heart. So having that in mind, we also need to remember that your blood pressure equals to your cardiac output and your systemic vascular resistance, whereas the cardiac output is mainly because of the stroke volume and the heart rate. So these are the factors that are going to affect your blood pressure and your cardiac output. And because you're talking about volume in relation to cardiac output and venous return, I thought these are some of the things that you needed to have at the back of your mind before we go into the discussion. So why are we talking about volume and its relationship to cardiac output and venous return? Volume infusions are one of the most common clinical interventions that we give to a critically ill patient. So we actually kind of need to understand the relationship between volume and cardiac output. And the article we are going to be emphasizing on, or where we got most of the resources that I'm going to talk about, was done by a man called S. Magda, where he went ahead and did more literature review. You can check it out maybe afterwards, and went ahead and looked at more literature review so that it can help us understand what the books and the literature that's available tells us in relationship to volume and its relationship to cardiac output. So in that regards, we have important terminologies to talk about here. Number one being volume. So what do you mean by volume? Volume is blood volume, and blood volume can be and again subdivided into stressed volume and non-stressed volume, where the stressed volume accounts for 30% of your total volume. And this is one of the main determinants of flow. How does it determine flow in this case? So this stress volume creates the elastic recoil pressure that is important to generate blood flow. And so that's a crucial part in determining how blood flows in our circulation, whereas the non-stress volume is the remaining of the 70% of the blood volume that we have. This applies to both the heart and the vesicular, so it applies to both, to the entire CVA. So the heart has stress volume and non-stress volume, and also your vessels also have stress volume and have the non-stress volume as well. So knowing that, ideally, the stress volume is relatively constant under steady conditions. So if in a normal person, or in a person who's not unwell, or who's not going through any abnormal or conditions, then it is assumed that the stress volume is relatively constant throughout the time. And the other important thing to talk about is now the circulatory flow. So the heart creates circulatory flow by lowering the right atrial pressure, as we had seen. So when the right atrial pressure lowers, then the blood from the blood vessels are allowed to then be pushed back into the heart, using the stress volume as a determinant to help the flow back to the right atria. So the difference, the reduced pressures in the right atrium are the ones that will initiate the process of the blood flowing back to the heart, because ideally, if you look at it, then you have this stressed volume already in the vasculature that will help the flow of the blood from the vessels to the heart. So knowing those two things, so the stroke volume should ideally be equal to the stroke return. What does that mean? It means that the heart can only pump out what it gets in return. So for this stable state of the cardiovascular system, we are implying that the same amount, the amount that is pumped out, making the stroke volume, is equals to the stroke return that flows back from the circulation back to the right atrium when the atrial pressures are reduced in the cardiac cycle. So knowing that, then the mechanical characteristics of the cardiac chambers and the circulation thus are what determines the relationship between your volume and the cardiac output. And that is what we are also going to dig deeper into. So we've seen that volume will create the elastic recoil force, and that will cause a flow. So then what's the point? What does the heart, how does the heart come into play in this case? So on top of that, now the heart is responsible to add a positive component to the static potential energy, which will help redistribute the volume to the body. And this will be determined by the compliance of the system, of the blood vessels and the whole system, and the resistance that the blood will the resistance that the blood is going to face as it tries to pump out the blood into the circulatory system. So to try and explain this further, if you look at the the electrical circuit, the model where the Ohm's law is derived from, it says that the difference in the charge in the volts is equals to the current and the resistance, which in this case resistance is the energy that is lost due to the flow of the electrons by the conducting substance. So if we look at this analogy, for example, so if you're having a power source, such as a socket or a battery, so the voltage is what flows from the battery to the ground, level, or to whatever that you want the voltage to flow across. So what flows out is a product of the electrons that are going to be allowed to flow out, plus the resistance that is going to be faced for these electrons to flow out. So if we apply this to our cardiovascular system, we are saying that the pressure that you're going to get is equals to the cardiac output plus, times the peripheral vascular resistance that you encounter when you're trying to pump out the blood. But remember, we have said that the blood has a constant volume. So what it means is our source, or where the blood is coming from, ideally doesn't really change. So what will change, or what will determine the change, is the resistance in the vessels that we actually that the heart will actually face trying to pump out the blood. So if you try to and interpret what this equation is trying to communicate to us, is the volume per minute, which is the cardiac output that's coming out of the heart, is determines the arterial pressure, rather than the arterial pressure being determined by the volume per minute that flows from the systemic flow. So that means your cardiac output is what ideally is going to determine the arterial pressure, rather than the arterial pressure determining how much cardiac output is going to be pumped out of your blood. We are going to understand this further when we look at the resistance part of it. So if this volume we are talking about is constant, and it's affected by, and so the things that we are more worried about are the peripheral vascular resistance in the vessels, then we also need to talk about compliance. So what do we mean by compliance? Compliance is the measure of how much the vessels can distend, and in an equation is actually it's represented by change in volume over change in pressure. So if, for example, you try and blow air on a balloon, so and you put a specific volume in the balloon, then you measure the change in pressure that will happen when with this change in volume, then that is what we are referring to as compliance. Why is compliance important? Because compliance is also a key determinant to flow. Because the more compliant the system is, again, it's going to, at the end of it all, it's going to affect your elastic recoil force. So the more compliant the vessel is, or the heart is, then it's going to add up to the elastic recoil force that is important in the flow of blood, as you had mentioned earlier. Again, it allows for the pulsatile flow through a closed circuit. So what does this mean? So every compartment of the vascular system has different compliance. So depending on how compliant one system is to another, then it will also lead to the change in the pressure gradient, and it will lead to a pulsatile flow of volume from one area, which is probably high compliant, to an area that is low compliant. If we use analogy to try and explain this further, so if, for example, the vessels were stiff throughout and there is no compliance in the CVS system, that means the pressure that you try and pump in from the word go will be transmitted equally throughout the system, and there is not going to be any flow. For example, in this figure A, if you can see it, they're trying to explain, if you have like a bellow and try to pump fluid around a system that has stiff pipes and no compliance at all, the flow is not possible because the pressure on the bellow persistently raises the pressure everywhere, and there is no pressure gradient for the flow to actually happen. But in B, where you have an area that there is compliance and allows compliance, so an open area that will allow the region to be more compliant. Sorry about that. It will be able to allow change in the volume, and it will be able to change to allow also change in the pressures, so flow can actually occur, and it will therefore lead to a versatile movement of flow from the bellow side, as you can, because you're assuming it's like assuming you're talking about the heart, so it contracts and relaxes, so it keeps pumping. So every time it pumps, it transmits some pressure, or it forces some volume towards the vascular system. So every time it contracts, so there's a volume that is being injected into the vascular system. So if you have a region that is more compliant, then the compliant region will allow the flow of the blood in a versatile form, because the volume that has been forced in will again be pushed to the next region when the gradient goes low, and continuously like that. So the more compliant the region is, it allows for that continuous flow of blood from one system to another. If the compliance, again, if the area is very compliant, again, in this case, like in C, then as much as you continue pumping in the flow, the compliance is, the region that is compliant is too large, that volume or that force will not necessarily cause that versatile wave, and at the end of it all, it will just, because there's too much compliance, it will end up looking sort of like some ripples on the surface of the compliant region. So it will not give you the versatile nature of the compliance in figure B. So what we are assuming is our heart acts like the figure B in this case, in that every time you put some volume and the compliance is adequate, then it will end up causing that versatile flow of blood from one region to another. So with knowing that, we have areas, ideally we're looking at this from a point, we're assuming that the whole system, the compliance is the same, but we clearly know that compliance is different in different regions of the vascular system, and we have small venules and veins which are almost 40 times greater in compliance than the arterial vessels and the large veins, and then the capillaries have a lesser compliance to the veins. And then we also have the pulmonary system that only has about a seventh of compliance of that of the systemic circulation. So these areas having different compliance, then the areas that have big compliance that contain the systemic veins and the venules contain almost 70% of the total blood volume at a low pressure. So you can see we have already a lot of blood. We already have a lot of blood in the veins, meaning that the blood that is being pumped from the heart is a very small percentage compared to what is already in the circulation. So ideally, going back to our first explanation or our first point of stressed and non-stressed volume, and the fact that the veins themselves have their own stressed volume that passively flows back into the heart, mainly because of the reduction of the right ventricular pressure. So the volume that is being pumped from the heart, ideally, if you look at it, is a very small amount that cannot really cause so much difference into the systemic circulation, because you already have a very big portion of the blood in the systemic circulation. So this goes back to actually emphasize on the fact that the feeling of the heart is not mainly because of the cardiac output or the pressure that is coming from the pressure that is being transmitted into the aorta, rather than the recoil and the non-stress volume that we already have in the systemic circulation, because it already has a very big proportion of the blood that we need to pump back into the heart. So knowing that, we are trying to now get an understanding on volume and its relation to cardiac output. So we can clearly say that cardiac output necessarily does not play such a very big role in the in making sure that there is good venous return to the heart. There are other factors, mostly in the vasculature, that will affect the return of the blood to the heart, which we have seen to be, number one, the compliance and the resistance that we have in the heart, and the volume, or the non-stressed, the stressed volume that we have in the vessels will help bring back the blood to the heart. So in cases where you have sympathetic activity, in this case, the sympathetic activity, if you have like extreme sympathetic activation, that means it causes constriction of your vessels in this case, meaning that it will recruit more of the non-stressed volume to constitute for stress volume, and in return, then it will increase your venous return. In cases where you have reduced sympathetic or parasympathetic volume, it's the vice versa. So if you have, for example, if you have extreme sympathetic activity, literature has shown that it can recruit up to 18 mils per kg of the non-stressed volume into the stressed volume in this case. And that's something to consider, because if we reduce the sympathetic activity, then it will definitely lead to a reduction in our mean capillary refill pressure, which in this case, the mean capillary refill pressure means the pressure that is needed to actually allow the flow of blood from the capillaries to the systemic vessels in this case. So if you have a reduced sympathetic drive, then it will cause a reduction in your mean capillary filling pressure, and then in return, it will end up reducing your venous return in this case. So another thing that is being highlighted here is the capacitance of the vascular system. Capacitance in this case meaning the total volume that include both the non-stressed and the stressed volume in this case. So this capacitance, ideally, your total volume is around 5.5. It's about 5.5 liters, 5 to 5.5 liters in a normal 70 kilo man. So the total contained volume that can be contained at a given pressure, which includes the non-stressed and unstressed volume, is what we refer to as capacitance. Capacitance can be changed by contraction of or relaxation of your vascular smooth muscles. What we mean is, for example, what I was trying to explain, if we have a decrease in the capacitance because we have these smooth muscles of the veins and the venules being shortened or being contracted, and then it will recruit the non-stress into the stress volume of the total volume, and it will lead to higher pressures. But however, if you have a normal person, for example, that reduction in that capacitance or that contraction or relaxation of the muscle will then end up affecting your venous return at the end of it all. Going back to the analogy of compliance and capacitance in this case. So we have said there are areas in your blood, in your CVS that have high compliance, and there are areas where you have low compliance. But remember, this is one system. So what happens is, based on this model, they try and explain that if the two of them sort of work as one system, so the systemic circulation in full will work sort of in parallel. So those regions that have low compliance and then those regions that have low compliance, they work together, and at the end of it all, the total compliance in the systemic circulation is equal. So if you have, for example, blood being flowing in the system, so it will, you have a bigger sink, you have a bigger compliant area and a lower and a smaller compliant area. Your larger compliant area being the veins and the venules, and your smaller compliant area being your capillaries in this case. If we try and understand this further, for example, if you have maybe a bathtub and you have a tap that's filling water into this bathtub and you have an outlet. So what is going to affect the flow of blood from the tap to the outlet is not ideally the volume of blood that you pour from the tap. The depth of the water, or the depth of the water that will be accumulated in the tap, is what is going to create a pressure that will allow the blood to flow down the tap. So if you have a big tap, it's going to be harder for you to actually fill that tap faster, so that you can again drain the water faster, because it's going to take longer to increase the depth that you need for the outflow. But if you have a smaller sink, for example, then it's going to be easier for you to actually fill in the sink and affect the flow of the water from the smaller sink. So ideally, if you have the two systems working parallel, then that means the smaller sink that is draining faster will again drain into the bigger tap to kind of help increase the depth in this bigger sink, so that at the end of it all, when you're draining the fluid, when the water is draining, it's actually draining at the same rate. So if the system works like that, so you can see even if you increase the speed in this smaller sink, it's going to go ahead and contribute to the bigger sink, and at the end of it all, you end up having the same sort of output if they are working together in a parallel state. So that is also what happens in the heart. So at the end of it all, the whole system, as much as it has areas that have high compliance and areas that have low compliance, they work parallel together. And at the end of it all, the venous return is not very much affected based on the different compliance of the system. However, if you have resistance at any point, for example, if you need the heart to work and there's meaning you want cardiac function, you have the stressed and unstressed volume that are pouring into the right atrial pressure. So if you have resistance, then it's going to affect the flow of the blood. But if there's minimum resistance, then the flow is going to be more faster than when you have resistance. So in this case, the resistance will determine the flow of blood from the heart to from the heart to the vessels, and from the vessels to the right ventricle. So
Esther?
Yes?
Hello? I'm going to request you to summarize your presentation in the next 10 minutes.
Okay.
Thank you.
All right.
All right.
So, so from all these analogies that we've been talking about, what we are trying to understand is, or what they've been trying to explain to us is that we already have enough volume in the vessels, and the changes in volume that can occur due to cardiac output will not necessarily make such a big difference in regards to venous return. However, if you have peripheral resistance, or if you have anything that can affect the capacitance, for example, the contractility of the smooth muscles, then in that case, that will actually affect your venous return to your heart. So the major factor that affects the return of blood to the heart is mainly the pressure differences, the lowering of the right atrium pressure as an action, rather than the increasing the cardiac output and increasing the pressure in the aorta. Because even if you increase the cardiac output and you increase the pressure in the aorta, and yet we have the factors of compliance and factors of resistance, then they are going to, at the end of it all, the negative effect is going to be that they are not going to change venous return as much, so long as there is no difference in the right ventricular in the right atrium, I mean. So that pressure in the right atrium is what actually drives the flow of blood more than you increasing your cardiac output. So if you put that into perspectives again in terms of time constant, so if you increase the volume once in, if you increase the volume in the aorta, for example, one step increase, because the system is already compliant, then the result of it is going to be forming a new value potentially to change the whole dynamics of the vasculature. And this is what is called the time constant, meaning the rate at which the whole system is going to get to a 60% new steady state, because the whole system has to be changed by that change in the volumes. So if you increase, for example, the heart rate, then that means if you increase the heart rate, that means you're not going to give enough time for the heart to refill. And the end of it all is going to again lead to reverse. It's going to lead to reduced venous return, because it's not giving the heart time for it to be filled again. So mainly the implications of this is going to be that when you give your fluid therapy, the role of the fluids that you're actually going to give is not ideally to increase your cardiac output, but to sort of make a reserve, or to sort of increase your stress volume, because the stress volume at the end of it all is what is necessary for you to, it's what is necessary to actually bring the blood, to push the blood back to the heart. So when you give your volume, your infusions or your volume, ideally, that is the principle that's the principle that actually helps in this particular case. So increasing your stress volume so that it can actually increase the recoil, and it can facilitate the transfer of the blood to the heart and increase your venous return. So if, for example, in a 70 kg man, the stress volume we've said is 30%, so it's around 1.4 liters. So if you infuse about 1 liter of fluid, then you're going to increase your mean capillary refill pressure. And as you have seen, because of those dynamics of compliance and capacitance and the relationship in the circuit, then ideally you're going to pump a lot of blood, and most of the blood is going to be stuck upstream, other than flowing all the way to the heart, because again of the time constant issue. So at the end of it all, you have filled vessels, and that will probably lead to more vascular leakage, other than increasing your cardiac output and increasing your cardiac output, which ideally was your main objectives. So what they were trying to explain is when you're giving fluids to your patient, maybe pre-operative or patients who have bled a lot, you're actually just trying to sort of increase the stress volume so that it can make sure that you have enough volume in the systemic vascular system that is actually the main factor that affects the venous return to your heart, and then leads to the increased cardiac output at the end of it all. So I don't know if that makes sense, but so in conclusion, the using fluids ideally will not necessarily lead to your increased cardiac output, but if you give fluids, it will give you that reservoir that will help in the venous return at the end of it all. But mainly the dynamics of the system, the vascular system, has other factors or other determinants that actually contribute more to the flow of blood and later to the cardiac output in regards to the resistance, the capacitance, the compliance of the vessels. So all these are factors that you need to actually put in mind as you plan your fluid management in these particular patients. Yeah, thank you very much.
All right, thank you very much, Dr. Esther. That was wonderful presentation of the cardiac output and venous return physiology. So allow me to go back to the poll questions and then share the results. And then Dr. Esther, please feel free to respond to each of these questions. So the first one, I think in your presentation you covered, the heart cannot pump out more than it receives, and 96% of the audience agreed. The second one relates to the cardiac output, which organ receives the highest cardiac output. So the options were brain, heart, liver, and kidneys. And I think we had a huge percentage of the audience saying it's the liver, and that is true. Nearly 25-27% of the cardiac output goes to the liver. And so the next question is, and Dr. Esther, this one I'll ask you to come in because I think you talked about it, but I think the audience needs to verify the answer. The following determinants of cardiac output except, so stroke volume, heart rate, arterial blood pressure, and afterload. 83% of the audience said arterial blood pressure. Your comments? Dr. Esther, are you still there? Please unmute. We are not hearing you. Esther, you're muted. Hello? All right. I think maybe she's not able to respond at this time. So Dr. Esther mentioned that the cardiac output determines the arterial blood pressure and not the reverse. So 83% of the audience were actually correct. The arterial blood pressure does not determine the cardiac output. All the rest will determine it. Then Dr. Esther, if you can respond to this question regarding circulatory system. Oh, it's all right. You can respond to this one regarding the circulatory system and volume. Which of the following is false? So the first option, systemic circulation is less compliant than the pulmonary circulation. Comments on that? We are on number 4 regarding the circulatory system. Is the systemic circulation less compliant than the pulmonary circulation?
The systemic circulation is more compliant than the pulmonary.
Is more compliant. All right.
Yes.
So that was our answer. Yes. And I think that is largely because the systemic veins and venules actually are the most compliant. And I think you mentioned that they're 40 times more compliant than all the other vessels, including the large veins, the arteries, the capillaries. They're 40 times minimum more compliant. And so they hold the highest amount of volume. And then the other aspect is, yes, 70%, and I think you mentioned that. And intravascular volume is both stressed and unstressed compartments, and none of the audience thought that was false. And then, of course, we had a part of the audience saying they're here to learn. And then number 5, second last question regarding the circulatory system, which of the following is true? I'm glad none of the audience selected stressed and unstressed are a myth. And these are actually true volumes and compartments. And then Dr. Esther, is it true that 30% of the blood volume is unstressed?
No, 30% is stressed, 70%
30%
is unstressed.
Unstressed, yes. So 30% is stressed, and that is the one that actually flows within the circulatory system. 70% of that is actually largely static. And then increase in vascular capacitance reduces stressed volume. Is that true or false?
That's false.
Yes. So pardon, you said it's false?
If you increase the vascular capacitance,
Mm-hmm.
you're going to, yeah, it is false. It does not increase the stressed volume.
So it reduces the stressed volume.
Yes.
So therefore the statement is true. I think it is true, yes. I think
yes.
that is the true. Yeah,
Yeah.
so basically, if you think of capacitance as a bathtub versus a sink, a bathtub has more capacity than a sink. And so if I put volume into a bathtub compared to a sink, then that means there's going to be more stressed volume in a smaller compartment than in a large compartment. So that means if you increase vascular capacitance of the blood vessels, then that means you're going to have less stressed volume compared to if it was in a very small compartment. And then mean systemic filling pressure is the same as mean circulatory filling pressure. And I think that is not correct. The mean systemic filling pressure is on the venous end of the circulatory system, while the mean circulatory filling pressure is the entire circulatory pressure when you stop blood flow in any patient. The pressure that equilibrates throughout the entire vascular system is the mean circulatory filling pressure. And then the final question relates to venous return. Which of the following increase venous return except, so Dr. Esther, if we increase the mean systemic filling pressure, do we increase the venous return?
Yes, if we increase the mean systemic filling pressure, we do increase the venous return.
All right. What about what's the effect of norepinephrine on venous return?
It does not increase the venous return.
So norepinephrine is an alpha-1 and beta-1 agonist.
Yes.
If you give norepinephrine into any human being, one of the effects is to vasoconstrict or venoconstrict, in this case the splanchnic circulatory system, and so that means it will reduce the capacitance that is within the splanchnic venous system, and therefore push the blood out of that region. And I think you somewhat mentioned that, and it will push it back into the heart. And the wonderful thing about norepinephrine with its beta effects also causes a bit of either it will cause venodilation in terms of drainage from the splanchnic system back to the heart, or it will have no effect because of the beta-1 and beta-2 cancelling out with the alpha-1 receptors. So that is potentially why norepinephrine is probably considered the first-line vasopressor agent, because it doesn't just cause arterial vasoconstriction, it also causes increased venous return. So unlike phenylephrine that is purely alpha-1, and while it will have similar effects like norepinephrine, it will actually end up causing reduced drainage from the splanchnic circulatory system back to the heart. And so we don't see an increase in cardiac output usually when we use phenylephrine, but we see either in the same cardiac output or an increase in cardiac output when we use norepinephrine. And then increased lucitropy, would you like to respond to that? Does that increase venous return?
Increased lucitropy in this case means increased relaxation of the time, relaxation of the heart. Yes.
Yeah.
So it will give time for the heart to actually feel the preload to be more. So it will increase. Yeah.
Yes, and that will also reduce, like you mentioned, the right atrial pressure, and therefore allow more like something similar to the suction effect for venous return to get back to the heart. And so that will increase venous return. And once you increase venous return, the idea is you should be able to increase the cardiac output. All right, I think that covers that topic, and I hope that we have picked up the important points. I'll just check the charts. The effect of adrenergic drugs. What's your take on use of vasopressors to maintain cardiac output in sepsis? I think that has been at least to an extent responded to with question number 6. So I will stop sharing and then go request you, Dr. Esther. Thank you so much for the presentation, to stop sharing. We are going to go into the next presentation that is by Dr. Preach Kavata, who is going to tell us about, Dr. Preach Kavata is going to tell us about left ventricular function, time-varying elastance, and left ventricular aortic coupling. Dr. Preach is internal medicine physician and fellow of critical care medicine with a SCALE program. And he's also the head of the Chirudu ICU. Don't worry about him, he doesn't have Ebola, we thank God. So he's going to tell us about left ventricular function and its effects with time-varying elastance and left ventricular coupling. So Dr. Preach, I will stop sharing my slides and then allow you to be able to tell us, be able to share your slides, sorry, so that we can proceed with the presentation. But as you do that, I will launch another poll that is going to be related to the talk that you're going to give, so that the audience can try and follow what you're going to be discussing. So here is the poll. You should all be able to see it. If you can't see it, please tap the 3 buttons on your phone in the right lower corner, and then go to quizzes and polls and try to respond to the questions on that poll. So we shall give it about 5 minutes for the responses, and then we shall go into the presentation. So the first question here is, elastance is the opposite of compliance. Is that true or false? Just feel free to select whether that is true or false. And then the second question relates to the pericardium and the cardiac cytoskeleton. Do they limit the maximum diastolic volume of the heart? Again, that is a true or false. You just select one. Again, if you can't see the poll questions, please feel free to tap the three buttons on the right lower part of your screen if you're using a phone, or you should be able to see, if you're using a laptop, you should be able to see polls and quizzes button, and you should be able to respond to the poll and quiz that is here. The third question here relates to the end diastolic volume of the heart. Is it dependent on the maximum diastolic volume and the diastolic myocardial stiffness, true or false? And then number 4 relates to concentric hypertrophy of the LV. Does that reduce the LV compliance, true or false? And then the following factors affect stroke volume except, and we have listed about 4 factors: contractility, diastolic compliance, heart rate, and afterload. And then the other question is on diastolic phase. Is it shorter than the systolic phase? Is it made up of 4 phases? Has no effect on venous return. We are here to learn is also acceptable. And then the second last question relates to Frank-Starling's curves, and so does question number 8. So please feel free to respond, and we have about a few minutes to close this poll, and then we shall go to Dr. Preach. All right, we're left with about 2 minutes. And the responses are coming in, and we shall see them after the presentation, and request Dr. Preach to respond to some of the poll questions. And some of these questions, you should be able to answer them from the previous presentation, because they are all connected. I think Dr. Esther did a wonderful job in giving us an overview of cardiovascular physiology, and help us try and understand how the heart actually works and the circulatory system and the volume that is contained therein. So we have about 40 seconds left, and we shall close this poll. Okay, I hope the questions are not too tough, but if they are, just select any answer, and then we are all here to learn. So Dr. Preach is going to tell us the answers, and we shall discuss them at the end. So 20 seconds left, and then we shall close the poll. So if you haven't yet completed, please try and complete them as fast as you can. All right, so I'll stop the poll now and then allow Dr. Preach to take it away. Thank you very much. Dr. Preach, over to you.
Thank you for the introduction, Dr. Cornelius. I hope I'm audible. Am I audible?
Yes, we can hear you. We can hear you. Yes, we can hear you. Thank you.
Thank you. Thank you very much. So in the next 20 minutes or so, I hope to take you through this mouthful of a topic, left ventricular function, time-varying elastance, and left ventricular aortic coupling. You will notice the majority of the presentation will be to explain what these things are and to derive some formulas. And then I will end with some clinical correlates to make us all understand. So definitions are elastance in medicine and physiology. It is usually a measure of the tendency of a hollow viscous, for example, lung, bladder, or in our case, blood vessels, to recoil towards its origin, towards its original dimensions on removal of a distending or compressing force. The recoil pressure results from a unit distension or compression of the viscous. The reciprocal is compliance. We shall see how we derive it. But basically, it's just the ability to go back to its original state after being exposed to either distending or a compressing force. And it has to be hollow organ. Now, left ventricular aortic coupling, this characterizes the interaction between the myocardial contractile function and the load opposed by the arterial circulation. At this point, it may not be very clear, but we shall go ahead and see. Now, just to be very clear about the cardiac cycles, it's very important to understand this because as we move further to the pressure volume curves, this is very important. So ventricular systole has three phases. We have the isovolumetric contraction, rapid ejection, and slow ejection phase. Ventricular diastole has isovolumetric relaxation, rapid filling phase, diastasis, and then the atrial kick or the atrial contraction. Now that we know this, we can now go to the pressure volume loop and we see where these are. If we start with this one, the pressure volume relationship, basically the y-axis is the left ventricular pressure and the x-axis is the left ventricular volume. We end up drawing a curve that is, for example, if we start here, this is the curve that we end up drawing. And this curve is very important because this part A represents represents ventricular relaxation. Here we have isovolumetric contraction and then ejection, then isovolumetric relaxation. So between these 2 points, we have end diastolic volume and end systolic volume. and therefore the difference of this is the difference of these to the stroke volume. When the afterload is increased, what happens is that the stroke volume reduces, but then this curve ends up coming into place. Now, if we come to this other pressure volume loop, it is more detailed and it shows us what's happening at every point. At the end systolic volume, that's where we have the mitral valve opening, and this is where the filling happens. And Dr. Nyambura clearly explained it with an atrial kick. Now, at this point, it is very important where we have the isovolumetric contraction. Between these 2 points, we have isovolumetric contraction. There's no change in volume, but there's a significant change in pressure. Then the aortic valve opens. Then we have the ejection phase. And then here we have the end systolic pressure. And this is where the aortic valve closes. And then isovolumetric relaxation. And this comes back to the cycle. Now, ventricular aortic coupling, let me just define it again. Now, this characterizes the interaction between the myocardial contractile function and the load opposed by the arterial circulation. So when the heart contracts, it finds the aorta, for example, in the left side. And now the interaction between these two, now that is the coupling. Once blood comes from this side and it goes through to the rest of the body. Now, ventricular elastance. It is very important for us to understand ventricular elastance. Now, remember the pressure volume loops that I showed you. Now, once these pressure volume loops are exposed to different afterloads and to different end diastolic volumes, we end up forming multiple pressure volume loops. And even they keep changing from beat to beat. Once the point of attachment, just remember this, the end systolic pressure, okay? Now, once you attach multiple end systolic pressures, you end up with a straight line. And that straight line is referred to as the left ventricular systolic pressure relationship line, okay? So this line is the curve that connects various end systolic pressure points when the heart is exposed to different afterloads at the same contractility. It's important to understand it. Now, left ventricular elastance slope. Now, the slope of this curve is elastance, and that's important to understand. Now, if you remember mathematics, a slope is, amongst other things, change of y over change of x. So when you do the change of y over change of x, and we have said our y is pressure, our x is volume, you end up with an elastance, and that is the left ventricular elastance. So it is very important to understand that the left ventricular end systolic pressure relationship curve represents the left ventricular elastance. Now, the left ventricular elastance basically is equal to the left ventricular contractility. Because from what we have said from the beginning, elastance is the ability to go back to the original size once the distending or compressing force has been removed. And as the previous presenter said, in the Frank-Starling's law, force of myocardial contraction is directly proportional to the initial length of cardiac muscle fiber. So it's like you're working from backwards. So elastance, ability to go back to the original, is literally left ventricular contractility. Please remember that as we shall see it later. Next, we shall look at aortic elastance. Now, aortic elastance, again, the ability to go back after blood is deposited there. Aortic elastance is the slope of the line passing through the pressure volume loop at the aortic closure point. Remember, in the original, let me just go back here. Yeah. At this point, we have the aortic valve closing. So a line passing through here, it is the aortic elastance. Now, aortic elastance, again, if we are to do if we are to find the gradient, change of pressure over change of volume, we shall end up having the end systolic pressure that is there divided by the change in volume, basically from here to here, that's the stroke volume, and that's how you get aortic elastance. Now, coupling, as I've said, it's how the left ventricle and the right ventricle, how the left ventricle and the aorta interact. At this point, you can notice that we have the end systolic end systolic pressure volume relationship line and the aortic elastance line. At the point where they interact, now that is coupling. Now the ventricular arterial coupling is this point where they interact at the intercept, and to get left ventricular coupling, to find its ratio, it is the ratio of the arterial elastance over the ratio of the left ventricular elastance. That is very important, and I'll demonstrate it in a number of things. Therefore, in pathophysiological states, you have uncoupling, meaning the interaction is not the same. Now, for purposes of the left ventricle, the normal coupling, if we are to put values and you calculate it, in health, the coupling is about 0.6 to 1, okay? So up to 1, that is okay. If the coupling is more than 1, then there's a problem, and I will demonstrate it ahead. Now, time varying elastance. Now that's very important to remember. Again, these are the same pressure volume loops that I've shown you. Now, at any time during the cardiac cycle, we have already established the cardiac cycle goes through these 4 points. At any time during the cardiac contraction, that's a cardiac cycle, let's say 50 milliseconds, a line can be drawn connecting the pressure volume points from each of the differently loaded contractions, defining elastance. So if we have differently loaded heart and we have at the same time point, you can draw a line and that will be elastance, okay? Now, ventricular contraction can therefore be regarded as time elastance. So basically, if you draw multiple at different time points, this whole process is now the ventricular contraction, and it is actually equal to time varying elastance, meaning at every time of the ventricular contraction, the ventricle goes back to its original state at different times, because I've clearly mentioned, for example, remember the definition of elastance is the ability to go back to the original state. And in ventricular contraction, in both the systolic and the diastolic phases, there are multiple phases which happen at different times. So when you combine all that, that becomes the time varying elastance. Now, pressure volume area. Now we are going a bit higher. Now, if we are to find the area within this normal cardiac area, for example, this is a cardiac cycle. If we are to find this area, that area is actually defined as the external mechanical work. This is the work that the heart does, okay? Now, pressure volume area is equals to area within the cardiac cycle PV loop plus area under the end systolic pressure volume relationship line. Now, it's very important to understand that because PVA correlates with myocardial oxygen consumption. This area, if we add this and this, it will correlate to myocardial oxygen consumption. The logical thing to say or to ask is that if this loop represents the cardiac cycle, why do we have to also add this to make it a whole to correlate with oxygen consumption? And that is for a very simple reason. Remember, the heart uses oxygen during contraction. Now, remember, we have 2 phases of isovolumetric contraction. There is no change in length or volume, but there is actual contraction, and that is also energy dependent. Now, the isovolumetric relaxation, isovolumetric contraction here, all those are put into consideration by adding the potential mechanical work. So when you add these 2 areas, therefore you end up with a correlate of myocardial oxygen consumption. Now, clinical correlates. Contractility, let's start with this side, contractility. We see we have different loaded hearts. Now, baseline is the red one. Let's say this is a normal one. If you give someone esmolol is a beta blocker, it will reduce contractility. We can see that the pressure volume loop will be much smaller, but also important to realize the end systolic elastance, the ventricular elastance, this one, ES. the ventricular elastance will be lower, because from the beginning, I have told you the way we derived it, ventricular elastance is equal to ventricular contractility. So if you give a beta blocker, it is negatively inotropic, therefore it will reduce the elastance. If you give dobutamine, which is positively inotropic, it will increase contractility, and therefore it will increase elastance. That's very important to remember. Now, if we're looking at the afterload, remember arterial elastance is the same as the aortic elastance is the same as the afterload. Now, if this is the baseline elastance and you give nitroprusside, which is a venodilating drug, what will happen? You'll end up dilating the periphery, reducing the afterload. Now, the afterload is equals to the aortic elastance. Therefore, the elastance drops. If you give phenylephrine, it causes vasoconstriction, and therefore it increases afterload, and therefore the aortic elastance will increase. Those are the basics. Now, if we are to integrate these two images, we can have a case whereby, let's say in cardiogenic shock. Cardiogenic shock, what happens? We end up with heart that is not contracting very well. Let's say it is this one, and therefore we have reduced the elastance. And then as a result of the reduction in the filling pressure, the body activates the neurohormonal mechanisms, including the release of renin, angiotensin, aldosterone, but also increased sympathetic tone, and therefore the vessels constrict. So what will happen? We shall have a reduced ventricular elastance because of the underlying pathology, but at the same time, we shall have an increase in aortic elastance, an increase in afterload because of the neurohormonal mechanism the body is trying to give us. Now, remember when the ventricle and when the left ventricle and the aorta are coupled, the formula is EA over ES. Okay, and we said the limit is between 0.6 and 1. So if we have a situation where ES, the ventricular elastance has reduced, that is the ventricular contractility, for example, in cardiogenic shock, has reduced, and EA has increased because of the neurohormonal mechanisms, what will happen? We shall have EA, which is the numerator, will be bigger, much bigger than the denominator, and therefore the ratio will be more than 1. When the ratio is more than 1, that means there is decoupling, okay? So what do you want to do to couple it back? You need to give what? Something to increase the ventricular contractility. And the thing that is there is dobutamine. Therefore, you'll end up increasing the denominator, and therefore the ratio comes back to 1. I hope that is clear. Okay. So, and sepsis and other infectious diseases can affect the heart, and you can play around with those. So, for example, let's take sepsis, where you have septic shock. Now, septic shock, before you go to the terrible areas, perhaps you could have the ventricular contraction is not so bad. So let's say the end systolic ventricular compliance is, elastance is normal. But then, because of the endotoxins and everything, what happens? You dilate the aorta. Therefore, the afterload reduces. Therefore, you have an E over this one. Therefore, it will be much lower than 0.6. And therefore, there is decoupling. So what do? You increase the afterload. Amongst other things, apart from giving fluids, you give your vasoconstrictor drug, and you end up increasing the afterload, and then you end up coupling the two. So I hope that is clear in terms of relating these two clinical aspects. The other clinical aspect I want us to talk about is how we integrate the pressure volume area in this. So we've already said when there is coupling, the arterial elastance and the ventricular elastance, the ratio of these ones is between 0.6 to 1. And the useful work is here. Now, in cases of heart failure, if we go back to our case, let's say cardiogenic shock, what happens? We have an increase in afterload, but then because the heart is not contracting very much, we have a reduction in stroke volume, okay? And therefore, at the end of the day, you could find that there's a lot of wasted energy here compared to this, okay? There's more potential energy that is lost because of the different mechanics that it is undergoing. And therefore, you have to couple them in order to go back to the normal pressure volume area. Now, having said that, it is important to just give a sneak peek about what happens in the right ventricle. It's a bit different, but let's see. So let me just maximize this. So let's come here. Perfect. Now, there are multiple phenotypes of right ventricular dysfunction when you have ARDS, okay? Now, you can have isolated dilatation and RA uncoupled. Now, the coupling of the right ventricle, this is just a preamble to our colleague who is coming. The coupling of the right ventricle is the opposite of the left ventricle, where the coupling, the ratio is end systolic pressure volume relationship, or the contractility of the right ventricle over the elastance of the pulmonary artery. So it's the opposite. And this actually makes sense. So think about it. Let's say someone has ARDS. ARDS has many complications, and amongst other things, it causes significant pulmonary hypertension. Now, the normal ES-EA ratio for the right heart is normally, it should be about more than 1, okay? That's a normal one, should be more than 1. But if you have a case whereby you have significant pulmonary artery hypertension, for example, in acute severe ARDS, what happens, the elastance of the pulmonary artery increases significantly compared to the elastance of compared to the contractility of the right ventricle. And therefore you end up with a ratio that is less than 1. So for the right heart, a ratio that is less than 1 shows there is decoupling. So what do you do? Amongst other things, you can give inhaled or systemic pulmonary vasodilators. You give vasodilators to dilate the pulmonary artery, and therefore you're taking back your ratio to about more than 1. So it's actually quite interesting in putting this. So having said that, we have seen there are multiple graphs that can help us predict where we are from, where we are going, and what is happening to the patient. So in conclusion, I will finish with a saying from Hippocrates around 400 BCE. So this is in his paper of the epidemics. The physician must be able to tell the antecedents, the things before, know the present, and foretell the future. Must mediate these things and have 2 special objects in view with regard to disease, namely to do good or to do no harm. Actually, this is the origin of that famous line, do no harm. Now, the act consists in 3 things: the disease, the patient, and the physician. The physician is a servant of the act, and the patient must combat the disease along with the physician. Therefore, perhaps by understanding all these curves and relationships, we might be able to help our patients who are critically ill and they have cardiovascular dysfunction. Thank you.
Excellent. Thank you very much, Dr. Preach. That was, I think, very succinct and clear. So I'm going to first go to the chat. There is a question raised. You mentioned that EA, the ratio of EA to ES, that is the aortic elastance to the left ventricular elastance. However, the other books mentioned that actually reverse the ratio. Are these the same?
Thank you very much for the question. So just remember, if we have EA over ES, basically elastance of the arteries over the elastance of the blood of the heart specifically, that refers, you are looking at the coupling of the left heart in relation to the aorta. Now, on the other hand, if you have the contractility of the ventricle over the elastance of the blood vessel, that is, you are looking at the coupling of the right heart to the pulmonary artery. And that's why I thought I should bring it, and just a sneak peek of the right ventricle so that you can understand everything that is going on. Thank you.
Excellent. Thank you very much. So Dr. Preach, if we go to the results of the poll, I think number one, you answered that in the first slide, and elastance indeed is the reciprocate of compliance. So if compliance is change in volume over change in pressure, then elastance is actually a change in pressure per unit change in volume. And I think Dr. Preach expounded on that. And then regarding, Dr. Preach, maybe you can respond to this regarding the pericardium and the cardiac cytoskeleton. Do these limit the maximum diastolic volume of the heart?
Thank you for that question. Yes, indeed, the pericardium and the cardiac cytoskeleton limit maximum cardiac diastolic volume of the heart. So let me give you some example that all of us commonly know. If you have pericardial effusion, as in, and you progress towards tamponade, what happens? The pericardium has so much fluid that it limits the diastolic filling of the heart. If the diastolic filling of the heart is limited, therefore the stroke volume will be limited, and therefore at the end of the day, the preload and other things. Yeah, so yes, it does affect it.
All right. The tricky question perhaps I may want to ask is, if we took away the pericardium, therefore, would certainly in this case, it would certainly, we would say that it would increase the maximum diastolic volume of the heart. So would that give us any advantage in terms of cardiac function if we base this on what Frank Starling said regarding the more the heart is filled, the more contraction we get? Would that be an accurate deduction?
Thank you for that question. It tends towards an accurate deduction. For example, if, the common clinical example is TB pericarditis. Now, if someone has TB pericarditis, this person is likely to have terrible dysfunction of the heart until they do a pericardiectomy, where they remove the pericardium, and therefore the heart is able to relax and therefore contract. However, if someone is normal and you remove their pericardium, Frank Starling's law has its limit. Force of contraction directly proportional to the initial length, meaning cardiac output is equals to the end diastolic pressure. But all this has a limit. At a particular point, if you relax too much, for example, in dilated cardiomyopathy, the force of contraction is not equal, because what happens, the actin and myosin filaments, they go across each other and they stretch too much that they cannot be brought back. Simple example, if you have a rubber band, you can pull it up to a particular point and it comes back to normal. If you pull it until you exceed its elastic limit, it will not come back to normal because of the dysfunction. However, this question, you can also look at it from the perspective of hypertrophic cardiomyopathy, where the cardiac cytoskeleton can actually limit. The ventricle becomes very thick, and therefore it will limit the ventricular filling. Thank you.
Excellent. I think for those of you who loved physics in your days, Pete just told us about Hooke's law. You stretch a spring beyond its elastic limit, and then it will snap or undergoes plasticity and then snaps. So the myocardium still has a limit to how much volume it can take. The third question relates to the end diastolic volume of the LV is dependent on the maximum diastolic volume and the diastolic myocardial stiffness. I think you've responded to that and also highlighted hypertrophy, and 93% of the audience did agree. And then you also hit number 4 at the same time regarding concentric hypertrophy that usually comes as a result of increased afterload to the heart, or maybe genetic variation, and all of that will decrease the LV compliance. Perhaps the question here to you, Dr. Preach, would be, if I have a very thickened left ventricle, should I then be cautious with the amount of fluid I'm giving, or should I duress these patients, or should I actually give them fluid? What would be the best strategy in this case, considering the LV compliance may be reduced with hypertrophy?
Thank you for that question. And that question plagues many people who are trying to manage heart failure with preserved ejection fraction where someone has hypertrophy. Now, remember the diastolic phases of the heart. We have the isovolumetric relaxation, rapid filling, diastasis, then atrial kick. If someone has a very thick left ventricle, it basically means blood is moving from the left atrium to the left ventricle. In normal people, when blood is moving this, as Dr. Nyambura said, blood moves from high pressure to low pressure. But what happens if you have left ventricular hypertrophy? It ends up being blood moving from the left ventricle, from the left atrium to the left ventricle, which is actually a high pressure. And therefore, that is why after some time, people end up with left atrial enlargement. So think about this case. You have a high filling pressure from the left atrium to the left ventricle, and then you give them fluid. If you give them excessive fluid, these people are very prone to getting a flash pulmonary edema. Now, I need you to remember this. In the diastolic phase, the period of diastasis basically means the pressure in the left atrium, the pressure in the left ventricle, and the pressure in the pulmonary capillary wedge are all the same. So, but in a case where you have a higher left ventricular pressure and you load them with fluid, the high pressure can easily push blood back to the pulmonary system, and you actually get a flash pulmonary edema. So in these people, it's actually quite difficult to manage. So ideally, what they recommend is like a beta blocker. If you give a beta blocker, what will happen? You will basically reduce the heart rate and therefore per se increase the diastolic phase and therefore diastolic filling, and then blood can be pushed out. So in such hypertrophic patients, you do not want them to have tachycardia, because if they have tachycardia, to be very bad, they'll have a high filling pressures, pulmonary edema. Therefore, you just need to reduce the rate of relaxation. Thank you.
Excellent. Thank you very much, Dr. Preach. Just on an addition to what you've said, which I totally agree with, once you have hypertrophy, whether it's on the left or the right, these patients are extremely, the ventricles are quite volume sensitive. They are sensitive to both very high volumes and very low volumes. So it's a very delicate balance. And I think Dr. Preach has hinted on that. You have to be very careful how you play with your volumes in such scenarios. Okay, number 5, the following factors affect stroke volume, except, so the audience was given 4 options: contractility, diastolic compliance, heart rate, and afterload. Dr. Preach, your take?
Thank you very much for the question. Now, the things that affect stroke volume from our graphs, which we have seen, basically afterload most definitely affects stroke volume. We have seen the higher the afterload, basically the ventricle pushing into a higher pressure, the stroke volume will definitely reduce. Now, diastolic compliance determines end diastolic volume, therefore, and the difference between the end diastolic volume and the end systolic volume is the stroke volume, and therefore, definitely, that one also affects stroke volume. Now, if we look at contractility, it's just basically the ability to shorten, the stroke volume, the contractility will also affect stroke volume. And therefore, what we are left with is the heart rate, although we need to be careful with that. Yeah, thank you.
Certainly. Yeah, so the heart rate may have an indirect effect, but direct effects are usually from the 3 that Dr. Preach has mentioned. And then number 6, which of the following is true regarding the diastolic phase? And I think you responded to this one. It is definitely not shorter than the systolic phase. And Dr. Preach mentioned the 3 phases of the systolic phase and 4 phases of the diastolic phase. The heart must function in such a way that it reduces, rather it increases venous return. And so God, or if in case you don't believe in God, there is a perfect design to allow that to happen by having diastole being a little longer, but also there are benefits in having a slightly longer diastole than systole because you get feeding of the LV. And then number 7, I think you showed the graph and of the Frank-Starlings. And so here the question is which of the following is true about the axis? And the x-axis is definitely not cardiac output, and so that option is not correct. And then the x-axis can be anything related to diastole. It can be end-diastolic volume, pressure, preload, whatever you want to choose. And then the final question was which of the following hearts is sicker? Is it A or B? Dr. Preach?
Thank you for the question. Yes, so if we are to investigate this, I'm happy to see up to 91% have mentioned B, and actually that is correct. The X is basically the end diastolic pressure, and the Y is the cardiac output. So the whole idea, if you compare between A and B, you can see in B, even if the end diastolic pressure increases for quite a lot, the cardiac output does not increase. And therefore this negates the Frank-Starling's law, which says the force of myocardial contraction is directly proportional to the length, to the initial length of cardiac muscle fiber. And basically that's the end diastolic pressure. Thank you very much.
All right, thank you very much, Dr. Preach. I'm going to introduce the next presenter, who is Dr. Ronald Bisegera. And Dr. Ronald is a new additional resident in the Department of Anesthesia and Emergency Medicine at Makerere, and he is going to talk about the right ventricle and the interaction with the pulmonary circulation. Dr. Preach has already hinted on that. So Dr. Ronald, please share your slides, but as you do so, allow me to share with the audience the second last poll question related to the right ventricle and the pulmonary circulation. Please feel free to respond to this poll. In case you don't see it, please go to your phone, click the three buttons on the right left corner, and then you'll be able to see the poll and you can respond to it. Is anyone seeing the poll? In case you are, please let me know. In case you don't, you can also let me know. All right, so we shall take about 5 minutes to this poll and allow the audience to respond. The first question is the commonest cause of RV failure is LV failure. Is that true or is that false? The second question is compared to the LV, acute myocardial infarction. RV myocardial infarction rarely causes cardiogenic shock. Again, that's a true or false option. Number 3 is the RV should function in such a way that it reduces the right atrial pressure to facilitate venous return. I think this is now easy for the audience to answer after the two presenters. Again, if you do not see the poll questions, please go to, and you're using your phone, please go to the three dots in the right lower corner of your screen that has more, and click on that, and it will show you polls and quizzes, and you can respond to these polls. We have about 3 minutes left. And so at the moment, I think we're getting some answers coming in. Please respond as fast as you can. Do not worry about being wrong. We are all here to learn. And Dr. Ronald is going to tell us about the RV, and we shall see the answers at the end and discuss them for more perspective. If you don't see the polls, please feel free to just send a text in the chat. So number 4 of the poll, the LV generates 50 to 60% of the RV ejection fraction. Is that true or is that false? Regarding RV physiology, which of the following is false? The RV is more compliant than the LV. The RV is adapted to handle high pressure. The precapillary pulmonary circulation is more compliant than the systemic arterial circulation. And if you're not sure, you can say we are here to learn. And then number 6 relates to the pulmonary circulation characteristics. Is it a low resistance, low pressure system? Is it a high capacitance system? Is it high compliance system? Although it may be 1/7 the compliance of the systemic circulation, or are we here to learn? Those are the options. And then in management of acute cough pulmonale, which of the following is false? Should we maintain the mean arterial pressure above the pulmonary arterial pressure? Should we give pulmonary vasodilators? Fluid management, is it delicate? Should we use ultrasounds to guide us in the therapy? Do we want a tachycardia in these patients? And then during mechanical ventilation, which of the following is probably bad in cough pulmonale? So the most correct answer, is it high FiO2? Is it a PEEP of 15, a tidal volume of 7, or are we here to learn? So we have about a minute left and we shall close the poll. We have a quarter of the audience that has responded so far, and many more are still responding. Thank you for the responses. We shall be closing the poll in about 30 seconds. So the faster you respond, the better. I think the questions at this point should be getting easier on the audience after the 2 talks. So the answers seem to be recurrent, but we are going to put more flesh on understanding the RV. So I'm going to close the poll in a few seconds now and hand over to Dr. Dr. Ronald Bisegura, please feel free to take over the presentation. Thank you.
Thank you, Dr. Cornell, for the session. I'm wondering if I'm clear and audible.
Yes, you are clear and audible. Thank you.
All right, thank you. So we are going to talk about the right ventricle and its interaction with the pulmonary circulation. I want to thank the previous presenters that have talked about the other parts of the heart. And now we want to look at the right ventricle that probably is less talked about in most of the discussions. Yet it is very key and we'll see its impact. In our outline, we are going to look at the basic anatomy of the right ventricle and some physiology. We'll see right ventricular filling. We'll talk about right ventricular ejection and then right ventricular afterload. In the basic anatomy, we have the right ventricle that is situated, just get my pointer. So we have the right ventricle, which we are going to talk about, that whose primary job is to push all the blood that it receives to the blood it receives to the pulmonary circulation without increasing pressures in the right atrium. So it pumps the blood through the pulmonary vessels and that reach the heart, and then blood is returned back into the left atrium through the left ventricle and then pumped into the systemic circulation. That is the basic anatomy and then physiology. We'll continue adding flesh to that as we go along. Traditionally, the right ventricle, its function, some people initially thought that maybe it wasn't of serious consequence in terms of its function in maintaining cardiovascular system homeostasis. But over time, it's been found that there are many aspects of the right ventricular function that affect the general body function, especially the cardiovascular system. In a normal individual, its impact is not that significant, like we shall see. But in sick individuals, we'll see its impact. And with the advent of the pulmonary artery catheters that are able to look at the heart in greater detail, they have revealed a lot of things that previously were not known. Like I said, the primary role of the right ventricle is to deliver blood to the pulmonary circulation beat to beat without increasing the right atrial pressures. A lot of the work that the right ventricle does is controlled by the left ventricle, which Dr. Preach has exhaustively discussed. And its contraction is what also supports the right ventricle to do its work. With the right heart catheterization or pulmonary artery catheterization, which sometimes you'll find called the Swan's-Ganz catheter, a lot of information can be got about the function of the heart and the state of the heart. The cardiac output can be determined using that right heart catheter. We can get the cardiac index, we can get the stroke volume, things that we are going to talk about that are derived from this catheterization. The pulmonary vascular resistance, the systemic vascular resistance, all this information can be obtained from the right heart catheterization. Frank Starling curves have already been talked about, that increase in the left ventricular ventricular and diastolic volume improves the performance of the heart to a level that at some point there is no more improvement in the function of the heart. So we'll see if the right ventricle obeys these rules, because they apply mostly for the left ventricle. We have alluded to this already, and we'll see that in the normal human heart, right ventricle, it feels below the unstressed volume. In other words, normally it doesn't fill up to reach levels of stress or levels that would increase the pressures in the right ventricle or in the right atrium. So, how this is done compared to the left ventricle, it does some conformational changes without necessarily causing any stretch to the right atrium, right ventricle. So you'll find that it is filling without any increase in the pressures in the right atrium, without any significant increase. So the descending pressures are not reached when it is feeding in the normal circumstances. So it means, like we said in the Frank Starling curves, increasing the end diastolic volume, increasing the end diastolic volume increases the performance or might increase the pressures. But in the right ventricle, we see that increasing the end diastolic volume doesn't necessarily increase the cardiac output as the left ventricle would do. And this was evidenced by one of the author of our major article that we're using for this talk, Pinsky. Professor Pinsky is a professor of critical care medicine. In one of his studies that was done earlier, showed that there was no relationship between the right ventricular end diastolic volume and the transmural pulmonary pressures or right atrial pressures. So increasing in this study, they were increasing the volume, they were giving fluid. This was a human heart. So adding volume and increasing the volumes, there was no change in the right atrial pressures. So they found that there was no correlation in the right ventricular end diastolic volumes and transmural right atrial pressures. Still regarding right ventricular feeding, the CVP, which is the central venous pressure, it does not predict volume responsiveness. This is because, like you have said, we have seen that there are when you increase the volume, say you give a fluid bolus, the right atrial pressures don't increase, and this is a proxy for the central venous pressures. So if you can, each time they are adding volume to the heart, it don't increase the pressures. So you cannot easily predict the responsiveness. But if you increase, if the pressures start increasing, then you have to stop giving any more volume, because any further increase in volume is going to cause right ventricular failure. So we have to be cautious. So that's why the CVP may not necessarily predict volume responsiveness. This was also given some flesh by Jardine et al., who studied patients that were in ARDS. These patients, when they gave volume, initially there was an increase in cardiac output, but there was no change in the right atrial pressures until at some point when, at a given point, when any additional volume, no matter how little it was, caused rapid increase in the right atrial pressures. So it became difficult to use, it gave more evidence that it's difficult to use the CVP as a predictor of volume responsiveness for that reason. Also, absolute right ventricular end diastolic pressures is a function of the pericardial restraint, pericardial pressures, and the intrathoracic pressures, rather than the right ventricular end diastolic stretch. So the work of this is the effort, the function of the RV is mostly a big percentage of it is contributed by the left ventricle, because it causes also the conformational changes in the right ventricle, like we saw that in the previous slides. So with the ejection, which I was already hinting on, is that there is a difference in the contraction of the two ventricles, the right ventricle and the left ventricle, that Dr. Pitcher has already talked about. The difference is that while in the right ventricle, let's start with the left ventricle. Left ventricle, the way it contracts is that it has longitudinal shortening. In addition to, it has longitudinal shortening as well as cross-sectional or circumferential fiber shortening. So it is along the longitudinal axis and then the circumferential axis, which I had a picture to demonstrate that. Whereas in the right ventricle, it's only in the longitudinal. In other words, it's like sort of a pipe. In a normal heart, you'll find that as if it's just a conduit to allow a blood to go through, compared to the right ventricle that has the circumferential contraction, which has around the heart, there's that shortening compared to only the longitudinal contraction. And hence the left ventricle contributes more on the ability of the right ventricle to have an ejection. So the pressures, so in other words, if in a patient that has some pulmonary hypertension and has failure of the left ventricle, if they are given a left ventricular assist device, it means it will work, it will improve the function of the left ventricle, but at the same time, it's going to cause failure of the right ventricle because because of the pressure. It's going to make the right ventricle work against a lot more pressure than what it would have. So you'll end up with failure of the right ventricle in case you had some pulmonary hypertension, in addition to left ventricular failure. So once the left ventricle has failed. It's one of the leading causes of the right ventricular failure. So once there's that failure, you're likely to get fluid retention that will be manifested as a peripheral edema, and might have some pulmonary edema as well, and then exercise intolerance because of impaired RV ejection function. So failure of the right ventricle causes cardiogenic shock, and this is how this happens. Once there are acute increases in the outflow of the right ventricle, say in a PE or hyperinflation. This hyperinflation, we are going to talk about it in later slides in detail. This will cause acute right ventricular dilatation because it has to work against a huge effort. And so because of the ventricular interdependence, you will have marked decrease in the left ventricular diastolic compliance because of its dilatation. The right ventricle is dilating. So we will have impaired left ventricular stroke volumes, and then we'll have the cardiac output reduced. Then we'll have arterial blood pressures also going down because of the lowered cardiac output. This will cause cardiogenic shock. So right ventricular failure can cause cardiogenic shock. Biventricular failure, this we talked about, and just emphasizing that failure of the right ventricle to do its ejection function will make the left ventricle also fail in the process. So it can be either way. The right ventricle can cause left ventricular failure, or the left ventricle can also cause right ventricular failure. So when left ventricular systolic function deteriorates, we'll have the stroke volume decreasing due to an increase in the left ventricular end systolic volume, which will increase the end diastolic volume of the left ventricle and the feeding pressures. This means the pulmonary vascular resistance is likely also to increase. But if it is unchanged, the increase in the left ventricular pressures because of the distension of the left ventricle will also increase the pulmonary artery pressures, which will increase the right ventricular afterload. So when the afterload increases, it means the left ventricle the right ventricle is going to fail because it is working against a bigger force or bigger resistance. So the combined decreased left ventricular contraction coupled with the increased pulmonary artery pressures is what can cause the biventricular failure. So it's a sort of a feedback. Acute coronary syndrome sometimes presents with hypertension, and we are going to see how this happens and how to manage this. So once there is an acute heart failure from acute coronary syndrome, this will initiate or stimulate an increase in the sympathetic tone, which will increase the arterial resistance and decrease the venous capacitance. Yeah, there will be some contraction of even the veins. So this will manifest as hypertension, tachycardia, pulmonary edema with elevated left and right-sided feeding pressures. So a patient will have features of volume overload. The first temptation is to give a diuretic to try to cut down the volume, but this is only going to worsen the circulatory shock. Instead, we should just reduce the afterload. So we are going to see some afterload reducing agents to improve circulation in such a patient that presents with shock and acute coronary syndrome. So we can have continuous positive airway pressure to abolish the negative swings in the intrathoracic pressures. Then also narcotics that work as sympatholytics to try to work against the sympathetic effect. And then pharmacological vasodilators like nitroglycerin that will reduce the afterload to allow the heart that is already weak at least to get some blood out as cardiac output and improve the circulation. Right ventricular wall ischemia can happen. And here are a few things that we can do to reduce it. Most of the coronary circulation in the right ventricle happens in diastole. Unlike in the left ventricle where it happens in diastole. So this means that if you have hypotension, okay, if you have hypotension where the pulmonary artery pressures are going to exceed the aortic pressures, it means you'll have coronary perfusion of the right ventricle, and this will end up as right ventricular ischemia. The treatment for this or prevention would be reversing the cause of pulmonary hypertension that's identified, and as well as giving some vasopressor to maintain the MAP above the mean arterial pressure above the pulmonary artery pressures, so that we can have feeding of the right ventricle. A caution with fluids that in case you have monitoring and you're able to measure the right atrial pressures, in case you're doing fluid resuscitation and pulmonary and right artery pressures increase, you are supposed to stop because maybe the patient might have acute copulmonary, like we'll see later. Acute copulmonary is when you have failure of the ventricle because of a lung disease, a primary lung disease, that is pulmonary. Ideally, it's not supposed to happen that the pressures are not supposed to increase, but if they increase, then it's likely that you're very close to the limits of the pressures in the right atrium are already affected. Right ventricular afterload is going to be our last part, that pulmonary circulation is capable of accommodating a lot of blood without necessarily increasing the pulmonary artery pressures. This is important for exercise, during exercises. The demands of the body have increased, and so even the blood that has to be oxygenated increases. So there is some level of compliance with the pulmonary circulation. So it's able to accommodate a little more blood. Although, like we said earlier, they talked about that it's about, is it a seventh of the compliance of the systemic system. So it has some level of compliance. It can accommodate more blood. So under normal circumstances, the right ventricular afterload is dependent on the blood flow in the lungs, as well as the degree of hyperinflation or increased alveolar pressures that may be present. So think about your patient that has to get on mechanical ventilation. There are implications for this patient. If whatever PEEP you have set, it might have an implication. Like we're going to see in the next slide. If someone has a pulmonary embolism, the flow is going to be affected, which will increase the afterload of the right ventricle. There are other things that can increase the afterload, including alveolar hypoxia. You remember the hypoxic pulmonary vasoconstriction. This will increase the afterload as well of the right heart. You have to solve some of these. So these are some of the danger things that can happen in a patient with pulmonary hypertension. Increases in lung volume is going to be, I think, our last slide, where we are going to see, we are seeing that once the lung volume increases, there can be implications on the tone of the pulmonary vessels. But although this can also happen independently, lung volumes can increase without changes in the pulmonary vessel tone. However, some cases, if it exceeds the limit, we'll have effects. And these, they mimic the cardiac tamponade. There is the selective cardiac compressive effect from lungs. This happens in that if there is, say there is inspiration, there is expansion of the heart. There is expansion of the lungs, yeah? Sorry, expansion of the lungs, there is expansion of also the thoracic cage. But this expansion, remember, allows the lungs to expand. The thoracic cage expands, even the lungs expand. Unfortunately, the heart is in its fossa does not have room to expand because the lungs on either sides are compressing on the heart. Like I'm going to show in this image. This image, we see the lungs might be able to expand, but as they're expanding, they are compressing on the heart, which is likely to affect to mimic the effects of cardiac tamponade. So there are some patients where I have to be cautious of this because it can end up impairing our right ventricular function. There are diseases that can mimic these effects or can exaggerate these compressive effects. And these include chronic, the COPD, chronic obstructive pulmonary disease, is one, especially the emphysematous type, where there is hyperinflation of the lungs. And this hyperinflation causes compressive effects on the heart, and then you'll have poor performance of the heart, and this will be manifested as exercise intolerance. This will cause impaired left ventricular feeling. Remember, left ventricle determines a lot of the function of the right ventricle. There is a study and an RCT that was done in the UK to try to test if using, they called it pharmacologic lung reduction therapy. They used a bronchodilator as well as a steroid. So in this, they wanted to sort of decompress the lung to reduce the compressive effects of the lungs onto the heart. And at the end of the day, they measured whether the left ventricular function improved, the right ventricular function and the left ventricular function, if these improved. This was given over a course of 7 days as inhaled therapy, and they did cardiac MRIs to see if there was any improvement. They found that there was significant improvement in the right ventricular function when in the group that received this therapy compared to the group that received the placebo. However, these they are not sure how safe this same therapy can be used in the long term. Remember, chronic COPD is a chronic illness, but in that short course, there was improvement. So they were trying to pick this concept of the cardiac compressive effects that happen in the normal person, then compared to the diseased person. So it confirms the concept that this hyperinflation can be disastrous to the right ventricle. And this same applies to sacropulmonary. If you have high PIPs, you're likely to cause more damage or poor function. Further reading, you can look up ventricular arterial coupling and then acute pulmonary management, and then the signs of these. My take-home points that I'd like you to remember is that the right ventricle is not the left ventricle on the left side. They are not just switching sides. They are quite different, and knowing that difference might maybe save a patient. The right ventricle doesn't obey the Frank-Starling curves as the left ventricle does. The CVP may not determine volume responsiveness. Then diuretics are not for every pulmonary edema. Sometimes you need after reducing agents versus using diuretics, which might worsen circulatory shock. And then probably advocate for pulmonary artery catheterization capacity in your centers. They might be helpful to some patients. You need to read more because there's more that I've not talked about. And last quote will be, now that you know these things, you'll be blessed if you do them. That comes from the New International Version. You may save a life if you know these. These are my references that will be shared for further reading and a lot of the studies that were done. Thank you all for listening to me.
All right, thank you very much, Dr. Ronald. Very well done. And I think you kept just slightly off the time, but it was good. All right, so there are some comments within the chat that I'm just going to read out. The first one is 50% of volume responsiveness. 50% will give volume responsiveness evidence by CVP, 50% won't. It's like tossing a coin. It's better to use the delta CVP and delta RAP. And I think Dr. Joyce Kalunji will elaborate more on the hemodynamic monitoring, especially when we're giving fluids. And then the other comment is, how will you clinically tell that the RV pressures have increased and hence halt fluid? JVP, comments, keep your comments very brief, Dr. Ronald.
Yes, you can use the right ventricle is the JVP is a proxy for the right atrial pressure. So we can use the JVP as a proxy for it clinically. For the bedside clinician, you can.
All right, thank you. The other question, I think it is at a fellow level. So Dr. Rasmus, I'm going to send it your way. One of the people in the audience has asked, thanks, please elaborate on the RV injury major phenotypes due to heart-lung crosstalk, such as occurs in ARDS, RVPA, uncoupling, and how the EAS ratio to the EA and TAPSI are affected. So I'm going to push that further up. Don't worry, Dr. Ronald, that one is not for you. And then relationship between the systemic hypertension and RV perfusion, please clarify.
All right. You're asking about the systemic hypotension versus the RV
yes.
perfusion. Yes. We say that the coronary circulation in the right ventricle, the right ventricle feeds more during systole. So it's about the cardiac output, it's about how much function is, how much systolic function there is. So if there is hypertension, that means the systolic function may not be good. So you will have less perfusion of the right ventricle. So that is how you'll end up with RV failure in systemic hypertension. So treatment is try to increase the mean arterial pressure above the arterial pressures, the pulmonary arterial pressures, so that you have perfusion of the right ventricle.
All right, thank you. I think one of the other important things to remember, and I think Dr. Arnold talked about this, is, and Timothy has also mentioned this with the RVPA coupling. It's very important that when the RV is experiencing a lot of pressure, you try to make sure that what has happened to it is that, of course, the myocardial oxygen demand is going to go up, and then the perfusion is not just in systole, but it's going to require even more perfusion during diastole. So the systemic pressures need to be adequate to allow the perfusion of the RV that is already being overworked. So systemic hypertension in an RV that is facing very high pressures that has undergone RVPA uncoupling means that you need to raise the mean arterial pressure or maintain it higher than the PA pressure. That will allow the RV to feed, while at the same time you're trying to reduce the pulmonary pressures to allow the RV-PA coupling to be restored. So the final question to you, Ronald, is effect of CPAP and intrathoracic pressure swings with RV function. I think he's asking what are the effects of CPAP and intrathoracic pressure swings with RV function. And I think maybe let me share the results and then we can respond to each of them, and hopefully that will be covered. The first question that we asked, the commonest cause of RV failure is LV failure. 63% of the audience says true. And Dr. Ronald, I think, mentioned this to also be true. And then compared to the LV acute myocardial infarction, RV myocardial infarction rarely causes cardiogenic shock. And this, Dr. Ronald, would you like to give a response, a brief response to this? Is RV myocardial infarction less likely to cause cardiogenic shock compared to LV myocardial infarction? Dr. Arnold, are you there? Hello? Okay, for the sake of, yes, Ronald, you're here, yes. Please respond.
Okay. Yes, LV infarction is more likely to cause cardiogenic shock than RV failure.
Okay, and I think that is true. I think Ronald at some point mentioned that the RV can act as a conduit. And so there are experimental studies that are available to see where they cauterize the RV itself, and there's almost no drop in the cardiac output. And so it's important that we understand RV infarction may not necessarily lead to cardiogenic shock as compared to LV infarction. And then the RV should function in such a way that it reduces, I think this has been answered, and 97% of the audience has captured that all the way from the 3 talks. Then the LV generates 50 to 60% of the RV ejection fraction. And I think this Dr. Arnold said it's true when he mentioned the effect of the LV on the RV. Number 5, regarding RV physiology, which of the following is false. So Dr. Ronald, is the RV more compliant than the LV?
No, the RV is less compliant compared to the LV.
Would you like to rephrase your answer?
The RV is more compliant than the LV.
Yes. Yes, the RV is more compliant, which you said earlier in your talk. And then the RV, is the RV adapted to handle high pressures?
No, it's not adapted to handle high pressures.
All right. So
yes.
that is false. It's not adapted to handle high pressures. That's
yes,
the false part.
It's the LV that is built for it.
Yes. So then I think the other option was precapillary pulmonary circulation is more compliant than systemic arterial circulation. That is actually correct. The capillary, if you look at the arterial end of the pulmonary and the arterial end of the systemic, you find that the systemic, the reason as to why it has the SVR is actually higher than the PVR is because the arterioles in the systemic circulation are a lot less, the resistance in them is much higher, the compliance is much lower, and that when you compare that to the pulmonary, it is actually much lower. So the pulmonary is actually much better than the arterial, but when you look at the entire systemic circulation, because of the venous end of the systemic circulation, the entire system and the systemic circulation is more compliant compared to the pulmonary system. And then number 6, the following is false regarding pulmonary circulation characteristics. So Dr. Ronald, is the pulmonary circulation low resistance, low pressure system?
Yes.
Okay, and I think that is true because the RV is not going to overcome high pressure systems. So it's the pulmonary system must be adapted to be low resistance and low pressure. Then does the pulmonary system have a high capacitance or a low capacitance?
It has a high capacitance.
Okay, so on the contrary, the pulmonary system actually has a low capacitance. So again, if you're thinking of capacitance, you want to think of it in line of a sink and a bathtub. Capacitance is the ability to hold volume. The pulmonary system, the reason why we get a lot of pulmonary edema once you give too much fluid is that it doesn't have the capacity to actually hold all that volume. It has a limit compared to the systemic circulation. So that's one of the reasons why you get acute pulmonary edema easily when you flood the patient with fluid. Especially in the lungs. And then what about compliance? Is this statement true? High compliance, even though it's 1/7 of the compliance of the systemic circulation?
Yes, it has high compliance to avoid increases in pressures.
All right. And then I think the second last question is regarding management of acute cold pulmonale. Should we maintain the mean arterial pressure above the pulmonary arterial pressure?
Yes, we talked about it. Yes, we should.
Okay, good. And then yes. And then the pulmonary vasodilatation improves outcome. That's also correct. I think we can get a comment on tachycardias. Should we, are tachycardias preferred when we have acute cold pulmonale?
Tachycardias cause more demand on the heart, so they are not preferred in that case. In terms of the feeling.
Would they also affect venous return?
Yes, they would affect the feeling.
Okay. All right. Yeah. So I think Esther talked about time constants. So the more you have a tachycardia, the less the time constant, and so you have equilibration or flow back to the heart is actually reduced because you have less diastolic time, and so the feeling, like Ronald has said, is affected. And then the final question is regarding mechanical ventilation. Which of the following is probably bad? So high FiO2, PEEP 15, tidal volume, which of those do you think, Ronald, from the options we have is the worst thing you can do for the RV? Probably the worst thing you can do.
Like we talked about the hyperinflation and its effects in COPD patients and RV function. So PEEP would be a mimic of hyperinflation for the RV, so which would create a higher afterload for the RV. So you would be worsening the copulmonary.
Okay. All right. There are other comments in the chat. We shall leave those to the end of this CME. But in the meantime, I think I'm going to go ahead and introduce the next presenter, who is Dr. Joyce Kalonji. Dr. Joyce Kalonji, just a second, is an anesthesiologist and a fellow in critical care medicine. She will be talking about an overview of shock and hemodynamic monitoring. She's going to bring all the things that we've discussed today into the clinical application in management of shock and monitoring. But this is more or less an overview of everything that we've talked about. So Dr. Joyce Kalonji, as you prepare to present your slides, allow me to launch a poll and then, or the final poll of the day, and then we can jump into the presentation. So ladies and gentlemen, here is the final poll for you to respond to. We shall take about 5 minutes and we shall close this poll. The poll has very simple questions, most of which you'll be able to answer, and they have true or false, and Dr. Joyce will give us the answers during the talk or at the end, and then we shall hand over to Dr. Erasmus to wrap this up and give us our take home, and then we can close. So Dr. Joyce, please share your slides as we prepare to finish this poll. We have about 4 minutes left to close the poll, so please respond as fast as you can. The first question relates to elderly patients who are in shock. Are they more likely to present with altered mentation? And then the second question relates to hypotension. Is it necessary? Is hypotension necessary in the diagnosis of shock? And then number 3, clinical signs of hypoperfusion are more important than blood pressure in shock diagnosis. Is this true or false? And then what lactate levels are considered significant in shock? Is it above 1.5, above 2, above 2.5? And number 5, regarding shock, which of the following is true? Usually one mechanism is present. High lactate always indicates shock. Fluid resuscitation isn't always the solution. We are here to learn. And then number 6 is relating to monitoring in shock. Which of the following is false? And the SCVO2 is used to assess the adequacy of oxygen delivery to tissues. The PCO2 gap is more sensitive than SCVO2. increase in the mean arterial pressure is very sensitive marker to good cardiac output. And then we're here to learn. And then the final question relates to fluid responsiveness and what is false. So bedside ultrasound is vital in shock. Functional hemodynamic monitoring is superior to static parameters. Passive leg raising is equivalent to giving fluid challenge. Again, if you're not sure, you can always say we are here to learn. We have about 2.5 minutes to close this call. So please respond as fast as you can, since we are badly running out of time. Dr. Joyce, I will request you to present your slides in approximately 20 minutes tops. Since we are going to have a lot more CMEs on cardiovascular physiology as well as shock, please make sure that you give the audience an overview and not the detail. All right, I think we have about 2 minutes and then we shall close the poll. Maybe I can take this opportunity to ask Dr. Erasmus to respond, to kill the time, to save the time. Dr. Erasmus, regarding injury to the RV and the major phenotypes due to the heart-lung crosstalk, such as in ARDS, how do these affect the RVPF coupling and the TAPSI?
Thank you so much,
the answer is probably within the question, but yeah.
Yes, the answer is in the question, but yes, Dr. Timothy, thanks for that question. First, perhaps I would like to say that next week we tackle a topic that specifically handles heart-lung interaction a little bit in more detail that should be able to paint the picture better. But nonetheless, you asked the question and therefore it serves an answer. So I guess I don't know how long I'll take to just help the rest of the audience understand, because I know the person asked knows the answer already.
We have 1 minute. We have 1 minute.
Okay, so what we call RV injury phenotypes actually are merely the stages of RV injury following increase in pulmonary resistance. And generally, you know, we see this with ARDS. We see that with the mechanical ventilation at high pressures. We see it with any condition that's going to increase the pulmonary vascular resistance when it goes on for a long time and acutely, because we know the RV is not designed to handle any increased resistance, to pump against any increased resistance. So we also know that pulmonary pressures pulmonary resistance interacts with airway pressures in a certain way. And so, you know, in normal circumstances versus in people who have got highly compliant lungs, and then those who have got poorly compliant lungs, like in people with ARDS, there's a way of that interaction happens. Now, when the lung physiology gets worse and there's increasing pulmonary vascular resistance due to, maybe in the case of ARDS, you're talking about from a disease itself, a bit of vasculitis with the increasing resistance, a bit of pulmonary hypoxic pulmonary vasoconstriction, worsening resistance, and then maybe you go on to perform mechanical ventilation. You might provide increased airway pressures, which are going to over-distend the few alveoli available, the so-called baby lung and the like, and that pressure is going to be transmitted to the intra-alveolar capillaries, worsens the pulmonary resistance further, and all this is going to be transmitted to the RV in a certain way. So now the RV is struggling against that, or more correctly, it's going to be transmitted to the pericardium initially, and when the pericardium reaches its maximum, this pressure now starts to distend the RV and basically fail its forward flow. So depending on at what stage you see this patient, they may present in a fairly compensated state where the RV is able to pump forward, which is like stage 1 and stage 2, but there is changes in either the shape of the RV or the coupling between the RV and PA. And then it may be at a stage where there's actually now worsening in ability of the RV to pump, which is cor pulmonale happening. So stage 3, stage 4 talk about cor pulmonale, where the RV has failed. So stage 1, basically you've got RV beginning to dilate, but there's still coupling between the RV and the PA. And in that case,
Dr. Rasmus,
the function seems okay. Yes, sir.
I'm
I hear
sorry,
you,
I'm
and I
going
guess
to cut you.
let me conclude basically. So I guess what I'm trying to say is that the 4 stages that the 4 phenotypes doc talks about are really more of the stages, and if you can identify a patient early enough, you might be able to prevent the RV from failing by modifying how you take care of that RV or the lung. But overall, I guess without dispelling too much of what we're going to discuss in future, we're going to discuss heart lung physiology. Then we are going to discuss pulmonary physiology as a topic of its own after this cardiovascular series, in which case we shall bring all these concepts together. But I hope this kind of helps, or at least satisfies Dr. Timothy a little bit. Thank you.
All right. So Dr. Joyce Kalonji seems to have lost connection. I think we can maybe give her a moment to return. I cannot see her online just yet. I think let me try and get in touch with her and see how far she is to getting back onto the network. Joyce, please present your slides and begin your presentation. Thank you.
Okay, good evening, everyone. I'm going to do the overview of shock and hemodynamic monitoring. I hope I can be heard well. Yeah. So shock is defined as a life-threatening condition in which the oxygen delivery, oxygen supply cannot meet the oxygen demand or the metabolic conditions of the body. So essentially, there's a mismatch between oxygen supply and oxygen consumption. So this leads to tissue or cellular hypoxia. And basically, the causes of shock are some of the things that have been so shock would literally result from a reduced cardiac output, either due to impaired cardiac function, decrease in circulatory volume, or obstruction of circulatory flow. And yeah, there's another type of shock that can be metabolic, sometimes due to poisoning, but that usually happens at a cellular level. So the types of shock can be distributive, as you'd see in septic shock or some form of SARS syndrome, or anaphylactic shock, and sometimes a neurogenic. And these basically are defined based off what the primary insult is. And so then there could be cardiogenic shock, hypovolemic shock that can be hemorrhagic or non-hemorrhagic, and then obstructive. So here, unfortunately, this slide cannot be seen so clearly, but this looks at the hemodynamic parameters in shock, literally the primary insult in a form of shock. So when you look at hypovolemic shock, usually, if you're to do hemodynamic monitoring, usually there would be a reduction in CVP or right atrial pressure. There could be a decline in pulmonary capillary wedge pressure. There's a decline in cardiac.
Joyce,
yeah?
I'm
Yes?
sorry, I'm going to hold you for a bit. Can you please put on the rotate version of your phone? I'm assuming you're using your phone.
Yes, I'm using my phone.
And then, yes, and then give us a landscape instead. Thank you.
Okay, let me try, but I failed. Ooh. Cornell, it's failed. Maybe what I can do is I can send you this
No,
on your
no,
email.
you don't have to. Let me just
Mm.
guide you. Please, on the right side of your phone, just slide down from the top right corner, just slide down and then go to the rotate function. Just slide down on the right side of your phone. Up to down. Are you able to do that?
Nope, I'm trying.
The way it is, just slide down. Just slide from the top to down and then go to your rotate function. Because it's cutting what we are seeing on our side. So we're not able to see most of what you're
slide
presenting. Yeah.
So I'm trying to do that, but I don't get what I can do possibly is just send you the slide, because I've put it in PowerPoint, but I still get like a PDF format when presenting it.
Okay, just proceed. It's okay. We don't have a lot of time.
Okay, sorry for that. So in hypovolemic shock, usually you'll have, because of vasoconstriction, usually you'll have an increased systemic vascular resistance as a total peripheral resistance, and therefore an increased afterload. And then usually there's a reduction in tissue perfusion. So while in distributive shock, you have a reduction in CVP, in pulmonary capillary wedge pressure, but usually you have an increased cardiac output, so therefore the cardiac output index is high. The systemic vascular resistance is usually low, and this is because of extreme vasodilatation. And of course, in the earlier phases, you will have increased tissue perfusion, but this quickly goes down in the later stages of shock. So cardiogenic shock can be divided into phases where you I'll particularly talk about LV dysfunction. So with the LV dysfunction, you will have an increase in right atrial pressure and an increase in capillary wedge pressure as well. There will be a reduction in cardiac output index, an increase in systemic vascular resistance, and a decline in tissue perfusion. While with obstructive shock, particularly we'll talk about the pulmonary vascular kind, you have a decline in, you have an increase in pulmonary capillary wedge pressure with a decrease in pulmonary capillary wedge pressure, a decrease in cardiac index, an increase in systemic vascular resistance, and a decline in perfusion, tissue perfusion. So the goals in management of shock largely are to increase oxygen delivery. So I hope you're able to see this. So on top there, you have oxygen delivery that's basically determined by two components. One is cardiac output. The other one is oxygen content. So cardiac output, this has been well elaborated by my colleagues before, is determined by stroke volume. Stroke volume, and one of the major determinants, of course, of stroke volume from the discussions we've had before are preload, afterload, and contractility. Heart rate can also be a major determinant, especially if you're having arrhythmias and other comorbidities. So when it comes to oxygen content, the hemoglobin concentration and the oxygen saturation are also a major determinant of oxygen content. So what you see there is the fixed low, and it's what is used basically in hemodynamic monitoring. So preload, I think preload has been well elaborated and well illustrated today as one of the determinants, a major determinants of cardiac output, in conjunction with so we've talked about the stressed volume and the unstressed volume and how all those affect mean systemic pressure. Yeah, and how also the compliance of different vessels affects mean arterial pressure. I will not go back into that. So basically, when you're managing shock, your major the goal of your management is to measure preload and be able to optimize it be able to optimize it either by giving fluids or vasopressors if the patient is fluid responsive. So we have to do that with caution because we know the consequences, the multisystemic consequences of fluid overload that are noted by that image seen there. So essentially, when you are so you have to have a systemic approach of determining whether the patient is fluid responsive or not. There are times when you receive a patient and there'll be no doubt that the patient is fluid responsive, or you're just starting your resuscitation. In this instance, you might not need to assess fluid responsiveness. But in all other instances, you basically need to determine whether the patient is fluid responsive. So there is at the start you start by so is there indication for fluid administration? So there may be triggers, either you've done an examination and there are signs of hypoperfusion, either tachycardia, or you can see a low cardiac output from your hemodynamic monitoring. So if those are present, then you'll assess for fluid responsiveness. And if the patient is fluid responsive, then you give after you've given your IV bolus of either 250 mils or sometimes even up to 500 mils, you will evaluate the effectiveness of your fluid. So some of my colleagues have talked about this. So in a patient in whom, if you're able to do cardiac output monitoring, so in a patient in whom you've noted an increase in cardiac output and there's minimal changes in your CVP or in your end volume lung weight, then that patient is still considered volume response, fluid responsive, and in that instance, you can continue to administer more fluids as you monitor. In a patient in whom the cardiac output is literally, there are minimal changes in cardiac output. There's a minimal change in cardiac output. There's a change in cardiac output with minimal changes in CVP and extra lung water. Then it's uncertain whether the fluids may be. You need to proceed with caution. So in a patient in whom you can see a vivid increase in cardiac output with increase in CVP and extra lung water, then in that patient, the fluids may be of no extra, may not add value, may not add any particular value. In patients in whom you see no changes in cardiac output, yet there are changes in CVP or things like extra lung water, then you need to stop the fluid administration. So preload assessment. So preload assessment can be done by various methods, many of whom are still largely inaccurate, but so they usually will have minimal value, again, as illustrated by some of my colleagues. So some of the methods that you can use to assess your preload include pulmonary capillary wedge pressure, central venous pressure, that usually correlates with right atrial pressure, and left ventricular end diastolic volume and pressure. All these have been talked about by the previous presenters, and the downsides to using all of them. The methods to use, particularly to assess volume responsiveness, include pulse pressure variation, stroke volume variation, passive leg raise, IVC collapsibility, and you can use a classic fluid bolus as well. The modalities to use for measurements of cardiac output include arterial pulse pressure analysis, lithium dilution-based devices, thermodilution-based devices, bioimpedance, aortic Doppler, and focus. So for tissue oxygen saturation, because most the measures noted above are largely upstream measures, they're dealing with cardiac output and preload. But remember, shock is defined as the cellular level as well. So you need to have modalities, or at least combine both modalities to understand tissue oxygenation. So there's the central venous oxygenation that should usually be above 70%. The lactates that should be below 2. And capillary refill times, these come in handy in low resource settings and infrared examinations. So we'll talk briefly about some of the methods. We will not talk about all of them. So there's preload measurements again that are 2 that we've talked about. One is using the pulmonary arterial catheter, which you basically insert and you thread through the right atrium all the way to the right ventricle, and then you go to the pulmonary artery, as you see in this diagram. And if you you can be able to measure the pulmonary capillary occlusion pressure if you occlude the catheter at the end. So this, if you're inserting the catheter at the same time, usually doing monitoring at the same time, you're able to see different waveforms, because this catheter can give you a number of values. The CVP, the pulmonary arterial pressures, as well as the pulmonary occlusion pressures. So you're able to see different waveforms and different values. On this end is the CVP. Now, at the start of hemodynamic monitoring, the gold standard used to be the capillary wedge pressure, rather the capillary the pulmonary arterial catheter. But this, again, after this study, which was done to assess the effectiveness of right arterial catheterization in the initial care of critically ill patients, proved that it was done in about 5,000 ICU patients. And it proved that patients who had pulmonary arterial catheters basically had a higher mortality, there were higher costs, and they basically had prolonged ICU stay. So largely the inconsistent results, because it inconsistently measures both fluid responsiveness and preload in conjunction with invasive, adverse side effects that included arrhythmias, injury to cardiac structures, thrombosis and infection. The use of pulmonary arterial catheters has slowly died down in clinical practice. The other use of pulmonary arterial catheters, when combined with the thermodilution techniques, came in measurement of cardiac output measurements. And what would basically happen is you would insert a central line on one end and a pulmonary arterial catheter, and you would use either a thermodilution technique, as you can see here, connected to a monitor. Usually it can be calibrated, and you'd be able to get direct measurements as seen here, and some indirect measurements. So some of the direct measurements, the combination of a pulmonary arterial catheter with a thermodilution technique, would be the CVP, the right-sided intracardiac pressures, pulmonary arterial pressures, pulmonary arterial occlusion pressures, cardiac output, and mixed venous oxygen saturation. And there would be some indirect measurements that you can also get via calculation. So it was quite elaborate, but again, some of the adverse effects and the invention of other less invasive measures has reduced the use of the Swan-Ganz catheter. So you get the cardiac output using that formula, and it's usually the area under the curve. I hope that's relatively clear. So some of these, the pulmonary arterial catheter has been replaced by other thermodilution techniques. And yes?
5 minutes left on your clock.
Oh, 5 minutes. Okay.
Yeah.
So we so we are able to measure pulse pressure variation and okay. So I think let me talk about the pulse pressure variation and stroke volume variation. I'll also talk about POCUS and passive leg raise. So we are able to measure fluid responsiveness. We're able to measure fluid responsiveness using some less invasive methods. Basically, this includes pulse pressure variation or stroke volume variation. And here you will insert you will insert your arterial line, and you connect it to a monitor that's able to do this. So the pulse pressure variation basically measures it deals with the differences that occur during inspiration and expiration, the heart-lung interactions. So during positive pressure ventilation, because mostly these methods should be done for patients who are intubated and paralyzed, and with tidal volumes of at least 8 mils per kg, and in sinus rhythm. So what usually happens is during positive pressure ventilation, there's an increase in positive pressure during inspiration, and this will reduce the right atrial pressure and reduce the stroke volume. At first on the right side, and then later on the left side. So these swings in pulse pressure are largely noted more noted in patients who are volume depleted. So the pulse pressure variation and the stroke volume variation method will be able to compute these things for you and tell you if the patient is fluid responsive. So a patient who has a pulse pressure variation of more than 15% is considered to be volume responsive, while one with less than that is considered to be not volume responsive. The other method that you can use is POCUS, and POCUS has a number of incidences, including IVC diameter, looking at sometimes you're just eyeballing the left ventricle or looking at the left ventricular end diastolic area. So all those parameters can help you to assess whether the patient is volume responsive or not. The other parameter that can be used is a passive leg raise. And this passive leg raise is usually used in combination with another parameter, for instance, pulse pressure variation or stroke volume variation. So what will happen is usually the patient is in a semi-recumbent position, and you lower the head of bed, and then you raise the legs, and this will be like an automatic fluid bolus, because all the fluid from the lower limbs is going to come down to the heart, and then you're able to assess if the patient is fluid responsive or not. Yep, I think that's it.
All right, thank you very much, Dr. Joyce Kalonji, for that presentation. I think let's just jump right into the poll questions, and then you can respond to them. So regarding, I'm sharing the poll questions now. So number one, elderly patients with shock are more likely to present with altered mentation. The audience 100% says true. and then hypertension is necessary, which is correct. Hypertension is necessary for the diagnosis of shock. Dr. Joyce, your take briefly?
No, so yes, I agree. Elderly patients, I think you've completed that. Hypertension is necessary for the diagnosis of shock falls. It's not necessary for that.
So it's not,
because
it's not necessary.
Yeah.
All right. And then clinical signs of hypoperfusion are more important than blood pressure in shock. 94% of the audience says yes. I think this ties in with question number 2. So question number 4, all right. The question number 4, what lactate level is considered significant in shock? Comments, Joyce?
Greater or equal to 2 millimoles per liter.
Okay. Then regarding shock, which of the following is true? Usually one mechanism is present. Is that true or false?
No, it's false. I think usually one mechanism is. Usually one mechanism is present. I think that's false.
Yeah, so we have to always start from the assumption that at least more than 2 mechanisms are present, and we start to eliminate, and it's important to make sure that we do not miss any mechanism. Otherwise, if we don't identify it, we cannot treat it, and the patient will not make it. And then high lactate always indicates shock. Is that true or false?
That's false.
Okay, so it's not always, and I think we shall have time to talk about lactate and production and clearance. And then fluid resuscitation isn't always the solution. True or false?
Yes, true. Fluid resuscitation isn't always the solution. You need to assess whether the patient is fluid responsive or not.
All right, so regarding monitoring in shock, which of the following is false? SCVO2 is for assessing adequacy of oxygen delivery to tissues.
That's true.
Okay, the PCO2 gap of more than 6 is more sensitive for oxygen delivery than the SCVO2.
False.
Okay, so there are instances actually where the PCO2 gap may actually be more sensitive. So basically the way it's done is to draw an arterial gas and then draw a venous gas around the same time and look at the carbon dioxide. And what has been seen, even when someone has an SCVO2 of more than 70%, the PCO2 gap still seemed to show reduction in oxygen delivery if it was more than 6. So there's a bit of a shift in terms of which of the 2 to use, especially when you're trying to understand if the blood flow is adequate to deliver the oxygen. So this is actually, to an extent, it is true that the CO2 is actually more sensitive than the SCVO2. And then mean arterial pressure is very sensitive to marker for good cardiac output. Is that true or false? Yes, false. That's false. And I think you mentioned static parameters not being adequate. Final question regarding monitoring fluid responsiveness in shock, which of the following is false? Bedside ultrasound is vital. I think you agree that it is.
It is.
Okay, functional hemodynamic monitoring is superior to static parameters.
That's true.
And then passive leg raising is equivalent to giving a fluid challenge.
That's true.
Okay, and then we are here to learn. Yeah, so okay, so I'll end the poll right there. And I will invite Dr. Erasmus to make his remarks regarding all the talks, bring everything together, and then close this session. Dr. Erasmus, over to you.
All right, thank you so much, Dr. Cornelius. First, I know that we've been here for a while, now it's 10 minutes past time, but a big vote of thanks to first the audience for being here and giving us reason to carry on, and second to the presenters of the day. My role as Cornelius mentioned, just to close, but quickly I'll just try to put together a few things. The reason as to why we are going through this is that over the next 2 to 3 weeks, we are going to be discussing the core aspects of clinical cardiology in the ICU. without necessarily, being cardiologists, but being the acute care folks who can identify and respond to complications of disease. The heart being central, as you mentioned, our first reason for studying physiology here, makes it very important that we understand the basics. We selected some of the important topics so that you could understand this, so that, and probably be able to derive conclusions on how to handle the rest of the things. But there's a lot to learn about this. So quickly, on the first topic we had was on volume, volume, the role of volume in determination of cardiac output. And I guess the important concepts to talk about here are things to do with the two pressures, the mean systemic filling pressures, the mean capillary saturation filling pressures, and their impact on venous return. We talked about, if just so that we are ready for the next talk, which is next week, we're talking about fluid therapies in critical care. Please go and review Guytonian curves. The Guytonian physiology is the basis of our understanding of venous return in this case. Of course, there are new questions on the subject with the new theory being advanced, but we shall not talk about that for now. Kindly review that, and Dr. Magda is a disciple, hence this kind of concepts we share today. When you stretch to the aspect of RV function, it really helps us to understand that we must respect the RV. The RV is a feared ventricle for a good reason. So kindly always respect the RV and learn more about it, and understand that while it might be easier for most of us to take care of the LV, taking care of the RV requires a lot more nuanced stuff, and even with the best care, sometimes it's quite difficult when it fails. And yet the care we provide in ICU frequently fails the RV. In fact, there's some evidence that the moment that ventilating a patient, within 24 hours, there's already evidence of RV dysfunction at the myocyte level. And so by the time at 72 hours, most patients' RVs are quite dysfunctional, but of course, frequently they're just in the first or second stage of dysfunction. We shall learn about this with time as we go, but it's really key that we understand that the RV functions different from LV. The LV, as Dr. Preach mentioned, contracts, in different directions. So actually, Dr. Bisegra talked about it. The LV will contract in 3 different directions, and as such, it never relaxes. The individual myocytes will relax, but the LV does not relax. And unlike what we are taught, the LV actually contracts in different directions, and that's what causes the cavity to either collapse, to eject, or distend to admit fluid. So that's key to understand. But nonetheless, in regard to RV, on the other hand, the RV is a peristaltic chamber. And I like to use a weird analogy here. If you've ever witnessed dogs mating by the roadside, there's only one simple harmonic motion. And that's exactly how the RV will contract. We cannot display it on video, but basically the RV is such a simple chamber that you do not want to disturb too much, because once it fails, you lose the conduit to systemic filling, and as such, the patient will deteriorate. And then finally, the aspect of shock. I guess the most important concept to take first of all is that blood pressure is not equal to perfusion. Perfusion is what we're looking for, and as such, we are always searching for evidence of either adequate or inadequate perfusion, without necessarily compromising, or increasing the demand of the circulatory system and other organs are involved in body function. So it is key to remember that part, and therefore always look out for evidence of shock and intervene upon it. Fluid responsiveness, fluid tolerance, those are important concepts that we hopefully will put into perspective next week when we talk about fluid therapies, and I hope we pay attention. But on top of that, as AAU and Aau-Icsu, there's an upcoming conference where we shall be taking people through a pre-conference activity that teaches use of ultrasound in diagnostics, critical care, and some of that will be looking into cardiovascular ultrasonography. I hope that you guys will all pay up and come in and participate. Dr. Timothy Muimbo has been throwing in a few concepts into the chat. I hope that you guys will pick those up and go and review them further and always bring it up for discussion. Every presenter, every participant here has got a contact either within the AAU or within our circles as critical care practitioners that you can easily reach out to. So kindly always try to don't go to bed with an idea that you do not understand yet. Either have the push to investigate further, or ask questions so that you can close that chapter. So finally, next week we are going to be looking at fluid therapies in critical care. I would like to invite you to come in your big numbers again, let others know, come and participate. For tonight, and hopefully for the rest of the week, I would like to wish you the very best of the week and weekend. And thank you so much for participating.
All right, thank you and good night.